Broadcasting. Okay, so good morning everyone and welcome to the meeting of the Health Scrutiny Committee in January 1st of 2024. Before I start, I just want to give a warm welcome to Catherine Ecklow, who is joining us on the Democratic Service team to our left here. So Catherine's got a wealth of experience in the health scrutiny world, so really glad she's on board and with us for the committee, so welcome Catherine. Before we conduct the meeting's business today, I also want to obviously touch on the sad passing of Martin Gately. So Martin was the officer before Noel on the committee, many years supporting the committee as well as the council in general. Anyone who met Martin will know he was a fantastic person, fantastic officer, but also really nice to speak to and was such an asset to this committee as well as the whole council. So given his amounts of contribution we've had to the committee over the years, I'd like to observe a minute's silence in memory of Martin. So just give a couple of seconds for David to take a seat and we'll start with that one. David, right, David. Oh, before we start there. Okay, so I'm just doing a minute silence now, thank you. Okay, thank you everyone. So on to the agenda for today's meeting. First of all, we've got the minutes of the meeting held on 12th December 2023. I take it's an accurate record. Any comments on the minutes at all? No, just take that as read. Thank you. I'll sign those shortly. Item 2, apologies for absence. Catherine.
Chair, we have apologies from Councillor Carr.
Thank you very much. And I know Councillor Adams is running late with traffic, and I think Victoria is the one who's going to be presenting as one of their later items, so thank you for that. Item 3, declaration of interest by members and officers. Do any members present have any disclosure of pecuniary interest to declare? Any private interests? Sorry, Councillor McGrath.
My daughter works in the NHS as a nurse.
Okay, thank you very much. Councillor Eddy.
My husband's a community staff nurse.
Okay, thank you very much. Any other declarations? No? Okay, thank you very much. So, we go into the substantive part of the agenda, which is the first item 4, access to the NHS dental services. So, thank you very much for colleagues who joined us. We've got Rosemary and we've got Dr. Pavleen Lakhani, who's here with us today, and Victoria will be joining us shortly, saying she's stuck in traffic. So, before we go into the substantive item itself, just want to talk about the email that everyone would have received from representative of the Fluoride Free Alliance UK, asking to consider the letter. Obviously, I know all members have got the letter. I did go back to Dr. Morrissey about the letter because from how I read it, the inference was he believed that we were actually discussing the actual item of water fluoridation, the policy. Obviously, NHS colleagues have made reference to it in their presentation, which is their right to do so. So, obviously, members are more than happy to discuss the item when it comes up in part there. But as I've made it clear to Dr. Morrissey, we're not actually here to discuss the policy that went through full council itself. We're actually, as we see from the item itself, talking about access to NHS dental services as a whole. So, gone back to Dr. Morrissey, and obviously we're more happy to discuss the future if need be, but obviously that we're not discussing that substantial part of the item today. Obviously, colleagues are more than welcome to touch on it in their scrutiny questions if they feel relevant. So, okay, so I'm going to pick off now and hand over to Rosemary and Barney to introduce the item. Thank you.
Thank you, Councillor Wheeler. My name is Rose Lynch. I'm one of the Senior Commissioner Managers for Pharmacy, Optometry and Dental, and I lead on system areas in Derbyshire and Nottinghamshire. As Councillor Wheeler has referenced, our colleague Victoria from the Nottinghamshire ICB is currently running late in traffic, so she should be joining us fairly soon. We normally do have attending these health overview scrutiny committees. We normally have attendance from our local dental network chair, who I've got Pavni on my left hand side, representation from the ICB, which is Victoria, and also consultant dental public health. Fortunately, we don't have consultant dental public health today, and the reason why we normally have so many people is just so it enables that collaborative communication and conversation, so that you can ask those relevant questions. But we do what we can today, obviously in the absence of our consultant dental public health, and anything we can't answer, we will of course take it back and obviously come back to you via email. So next slide, please. So I'll take the paper as read, but I'll just pick up some of the salient points that are from the paper and just demonstrate the journey from March 2023, which is when we last were in attendance. And it will provide an update on the post-COVID dental recovery and the dental contract reform. So this slide tells you about, it's a snapshot that you should have seen from the last slide, which is the provision in Nottingham and Nottinghamshire County. So there's 107 NHS dental practices. We have one urgent dental care site, which is based in Rainworth, and that's your 828365. We have 5 community dental services, and that's a service for patients who are medically compromised. And then we also have the trusts as well, NUH for obviously the specialist services, and also domiciliary care as well as the intermediate minor oral surgery. You may wonder what intermediate minor oral surgery is, and that's for more your complex extractions. So if you go into a dentist and they're unable to extract a tooth, or some of the root has been retained, they'll refer you into obviously primary care, into IMOS. It did used to be in secondary care, but to assist obviously with the funding and obviously being mindful of the public purse, we managed to obviously commission that into the primary care. So you would notice, if you had a attention to detail, that we have lost 2 practices since March. They are in Bassetlaw and Newark, and what we have done with that activity is we have dispersed it into the local area within the local vicinity on a non-recurrent basis. The reason why it's non-recurrent is because we're currently working on the oral health needs assessment, and that should be available at end of March, and that will tell us where the deprivation areas are, where the areas of high needs are, etc., and it will help us in terms of that strategy, in terms of that place-based commissioning. Move on to the next slide. I'll pass this on to Pavni to talk through the next few slides, and then we'll switch back to myself.
Thank you, Rose. Good morning, everyone. As Rose mentioned, my name is Pavni Lakhani, and I'm the local dental network chair for Nottingham and Nottinghamshire. I'm also a practicing dentist. So in terms of the challenges, it has been widely accepted that the challenges for NHS dentistry existed prior to the pandemic. But actually, following that, there's an increasing challenge in terms of access issues, not just in Nottinghamshire, but nationally as well. And we've had patients reporting that they can't access an NHS dental appointment at their local dental practice, or that there's signs outside dental practices saying that they're no longer taking on any NHS patients. Prior to the pandemic, there may have been patients who were accessing private dental care, but as a result of the pandemic, can no longer afford that. So that may be also contributing to the increased need in accessing NHS dental care as well. Generally, there is a professional discontent with the current situation with the contract, and this is even following the contract reform that came into place. And I'll touch upon that in a moment as well. In terms of workforce recruitment and retention, there are plenty of dentists in the UK, but we don't have enough dentists working and delivering for NHS dental care. And it's not just dentists, but it's also the wider dental team that we need to retain and recruit in order to deliver NHS dental care as well. So we need to look at the long-term planning for the workforce and ensure that in the long term we have enough of a workforce delivering NHS care. In terms of Nottinghamshire itself, there are specific challenges. Now, I'm going to touch upon the vulnerable groups, so people with severe multiple disadvantages and looked after children or children in care who have specific challenges accessing a dentist or even making it to appointments, and we are working to address these challenges. But actually, it's not just them, it's every age group, every single person that I understand is also having the challenge of accessing dental care. So we need to look at this as a whole rather than just the vulnerable groups as well. Rose might have mentioned that we have had contract handbags, and whilst that redistribution of UDAs is happening, it's really important that we have that long-term sustainable financial backing to ensure that those UDAs are there for practices to deliver in the long term, but that they're distributed in a way that addresses the oral health inequalities across Nottinghamshire, and awaiting that report that is due to come out in March 2024, the rapid needs assessment that should help us set that direction of where that funding needs to be placed as well. In addition to this, I understand that lots of children have been accessing food banks post-pandemic or during the pandemic, and that need has increased. And the influence of this on their oral health is significant because it means that their diets might have changed during that time, and it led to an increase in their oral health needs. So they may need more complex dental treatment or a significant number of fillings and things like that as well. So we need to really understand this from the report that comes out in March 2024 as well. Can I have the next slide, please? Thank you. So the dental contract reform, which came about in October 2022, sought to address some of the professional concerns around the existing contract, but it also sought to address some of the access issues as well. Now, as I mentioned before, even though the contract reform happened, the profession is still discontent with this, and we can touch upon that later. But what the contract reform did do was introduce this idea of enhanced units of dental activity, and that aimed to support those patients who have a higher need of dental care. So it means that if the patient comes into the dental practice and they have lots of complex dental treatment, then the dentist who delivers that care is remunerated for that. So that means that if they need multiple appointments, then that remuneration should reflect that as well. And the idea was to incentivize dentists to deliver this care and also ensure that there was access for these patients who required that care as well. There was also the sort of introduction of, the NICE guidelines for the dental recall have been around for a while, but in the contract reform, it highlighted the need for dentists to follow this. And what that means is that if a patient comes in and they've got really good oral health and they're considered low risk of oral diseases, decay, oral cancer, and gum disease, then they would fall into a lower risk category, which means that they don't necessarily need to come every 6 months for their checkups. They could come every 12 months or even every 24 months. And the idea of highlighting this in the reform was that it means that dentists who follow this, and they should be following this, it means that it opens up appointments for those patients who are in dental pain, so need urgent dental care, or who have those complex dental needs that I mentioned and need lots of treatment. So with those patients coming every 12 months or every 2 months, you've got lots of appointments available for dentists to treat those people with high needs as well. And just going back to the recall, it means that if you're high risk, for example, you've got lots of decay and you've got other risk factors, then you might need to be seen more regularly, so every 3 months or every 6 months, and the dentist can decide that when they see that patient as well and put them on that recall. There was also the introduction of the new minimum indicative UDA value, and this meant that practices who were being paid below this value were then raised to this level, and this happened nationally. But for Nottinghamshire, it meant that 4 practices were actually who were being paid below this value were then raised to this new minimum indicative value. And the reason for doing this was to help support practices with the increasing financial costs of running the dental practice. Another introduction was the use of skill mix. So there is not just the dentist and the dental team, but you've got dental hygienists, dental therapists, and they're actually trained at the undergraduate levels to deliver certain care for patients. And the idea was to utilize their skills to get more patients through the door in dental practices and being treated by the dental hygienists and dental therapists. And in Nottinghamshire, we have seen an increase in the delivery of care by dental hygienists and dental therapists under the NHS, and that's a good sign. In the long term workforce plan, it plans to deliver 15% of the dental activity through the wider dental team, which involves the dental therapists and hygienists. And the idea is that dentists are still going to be around, but they should be delivering that more complex dental treatment, which sits outside of the skill mix for the wider dental team. And there was also the idea of improving information for patients. And the reason for this is that we get lots of feedback from patients. They say, I've seen the NHS website and the directory of services, and it says that the practice is taking on NHS patients, but when I call them, they're saying no. And it was a mandated thing that practices now should be updating the website every 90 days to say whether they're seeing NHS patients or not. And the idea is to reduce that resistance and friction for patients who are looking for a new dentist or looking for NHS care as well. So I've touched upon how this affects Nottinghamshire generally. So there should be an increase in seeing more patients because of the recalls, the 4 practices that were raised to the minimum UDA value, and the long-term workforce plan of increasing the number of patients seen by the wider dental team as well. So we have had feedback from our Health Watch colleagues that patients are calling them less and less about issues accessing NHS dental care, but I think that we're all concerned that that doesn't necessarily reflect that and things are improving. It might be that patients are sort of giving up on that, and we don't really take that as a sign of things improving. So we need to be very aware that although patients might not be raising this, there is still a huge problem with access, and we're very aware of that as well. Can I have the next slide, please? Thank you. Thank you for allowing us to just touch upon the water fluoridation. And the reason for this is that it has been, stated that water fluoridation is an effective and safe public health measure to reduce the frequency and severity of dental decay and to narrow those oral health inequalities. And I appreciate that it is a contentious issue, and we may have a floor to discuss that later on at another date. But just to highlight the need in Nottinghamshire and Nottingham City. So over a third of 5-year-olds, so 34.2% in Nottingham City, display visual signs of tooth decay. And in Nottinghamshire, although the levels of tooth decay are better than the rest of the England average, almost a fifth of the 5-year-olds still experience dental decay. So the idea is that water fluoridation would prevent decay from happening and therefore reduce the number of general anaesthetic dental extraction appointments in Nottinghamshire, so reducing the need for hospital admissions for children as well, reducing the need for children to take time off school because they're in dental pain or they're missing school because they have to go to the dentist so frequently. And water fluoridation doesn't just influence the dental risk of children, but also there is a benefit to adults as well. So I just wanted to touch upon that the idea that prevention is definitely better than cure, and if we can address this at a very early stage, then we can address some of those issues that people might face later on in life if they have dental decay and things like that. Thank you. I'm just going to hand it over to Rose now.
Thanks, Stephanie. Can I have the next slide, please? Okay, so this slide just touches upon what's happened since the visit came from March 2023. Apologies, I didn't put my microphone on. Thank you. So this slide reflects what's happened since March 2023 when we last came to the committee, and to November at the time when the report was composed. I've captured just the January 2021 from the restoration recovery stage, and then between 21 and 23 was when obviously the immediate access initiatives were commissioned. And then from March to July, we had a journey where the NHS dental services were fully delegated to the Nottinghamshire ICB from the 1st of April. So that meant myself from the East Midlands Primary Care team, myself and colleagues, we were trooped over to Nottingham and Nottinghamshire ICB as the host organisation, but we do work on behalf of all the 5 ICBs. So it's been quite tough going for the team, as well as obviously all the ICBs getting to grips in terms of obviously the changes, but at the same time it's about ensuring obviously there's the smooth transition, obviously minimum impact as well on patients to ensure obviously the day-to-day job continues as well. With regards to the delivery, you can see on the at the end of the arrow in March, it was at 89.7% for Nottinghamshire, and unfortunately it's dropped slightly to 86.2%. With NHS dentistry, in terms of the access isn't static. It does go up and down. For example, it goes down quite significantly near the end of the financial year because dental practices are very eager to complete those courses of treatment so that they can claim that activity, because otherwise they'll be reconciled from the end of the financial year. And then you'll see in April it tends to dip again and then slowly peak back up again. So with the slight drop from March to November, that could be a various reasons, from likely the 2 terminations, it could be workforce, sickness, performance. But what we need to do is look at that data closely and have those close conversations with the providers to understand why that data is low, because it could be a number of things, perhaps software, etc. as well. So it's about having those collaborative conversations to understand why that is the case. We also need to engage with obviously the LDN chairs and the LDC chairs. So with Pavni being the local dental network chair, she links in with obviously the dental practices across the whole of Nottingham and Nottinghamshire, and it's about that clinician to clinician conversation to understand what is happening, and then Pavni then links in with us as a team and the relevant ICBs so that she can share those that feedback and concerns. Then we can look at ways of commissioning and also bringing that clinical expertise as well from the local dental network chairs, local LDN chairs as well, so that we can obviously look at how we can improve services for patients. Can I have the next slide, please? So as part of the recovery initiatives, I thought I'd just do a quick top level snapshot of what we've done without going into too much detail, because I'm just mindful obviously of the time of this meeting. So for 2022, you can see there was a number of initiatives that were commissioned. Firstly, it was about additional access, weekend access, and that was for practices to see patients, because it was noted that capacity had reduced significantly, especially with the infection prevention control protocols that were brought into place. So that unfortunately equaled less patients being seen. So by commissioning weekend sessions, it expanded that capacity. So that was done for 22-23 last year, and also straight after the pandemic. We also commissioned additional orthodontic case starts as well. We commissioned community dental services support practices. So we're Pavni mentioned children obviously challenges accessing dental practices. Unfortunately, sometimes dental practices do refer to your CDS practices automatically, whereas that isn't really the best place for patients with the children. So we have commissioned child-friendly support practices where the CDS are the actual gatekeeper. So say, for example, you're a dentist, you'll refer a child to CDS might will look at the referral and think, actually, this child will best placed in primary care rather than us. And we've got some of these child-friendly support practices who will then see the child and then obviously ensure that they're dentally fit. We've also commissioned IMOS waiting times to reduce it to 6 weeks or less. We also commissioned oral health promotion and improvement. That's by providing funding via the Section 256 to the local authorities, so that commission prevention out in the community. And then also the community dental services investment, that's again to support the waiting list. And that brings us to 23 and 24. The items highlighted in 22-23 is what is continued today. And then on top of that, we've also commissioned the vulnerable people and severe multiple disadvantaged groups for dental access, and those locations within Nottinghamshire are on London Road in Nottingham, and then they're in Change Grow Live Crown House, and that's a mobile dental unit to see those patients who may be maybe homeless or very vulnerable. So it's about closing those equality gaps. We also have dedicated urgent care slots. Now I'm really thankful for our dental practices because at the height of the pandemic, I managed to secure urgent dental slots on a voluntary basis from dental practices. It was a case of 111 being inundated. Can you help us support them, and in turn support you as well? So that helped with the pressures on 111. So dental practice may, for example, have 4 urgent dental care appointments per day, and they perhaps release 2 of them for 111, so 111 could directly book those patients in, and that is still in existence to today. So I'm really thankful for the dental practices in Nottinghamshire for continuing to do that since the pandemic. The next slide shows you further activity since the last attendance in March 2023, and this is for new patients being seen. So you can see that there's a clear decrease from March 23 for new adult patients, and there is an increase for new child patient numbers. For example, this could be capturing changes in terms of the number of surgeries that have changed. Access could have improved slightly, but we are looking at the data in terms of why there are influxes and where it has decreased. It can be seen clearly that, and also in the paper, that the Nottinghamshire County data is above the East Midlands and national data sets, but across the East Midlands, as of 10th of January, there's still a shortfall of around 619,000 appointments versus pre-COVID. So there is still a lot of work to do, and we recognise that. We recognise the challenges, and it's about working collaboratively as to how we can obviously bridge those inequality gaps and ensure some provision of care out there for patients. Move on to the last and final slide, please. So this slide is about the summary of the collaboration and future strategy. As I said, we've been integrated into obviously the integrated care boards from the 1st of April, and that helps in terms of that delivering that place-based commissioning, but also it can help in a wider footprint. So where I say that I work on behalf of the 5 ICBs, sometimes working at a large scale can be beneficial than at place scale, and it's just having that flexibility that we now have. There's oral health improvement, so again working with consultants into public health and the local authority, just to increase that oral health promotion in the community, so that prevention is key, as well as obviously the access. In terms of communication, there have been several stakeholder briefings from NHS England. We've also linked to directors of public health, and also we engage with local health watch. And in fact, yesterday I had the meeting with all the local health watchers yesterday, and that's where we share intelligence, because essentially they are the people's voice, and we take that on board quite seriously, and obviously listen to what they have to say and how we can change behaviours in dental practices as well. We also link in with consultants into public health. They have the expertise, they have the data sets, and that's what we're waiting for at the moment in terms of the oral health needs assessment refresh, which is expected at the end of March this year. We work with the local dental network chair, as I explained earlier, PAVNE, that collaboration at that neighbourhood level, and also with Health Education England as well, just to ensure that optimum provision of care for patients. We are working with the primary care Get It Right First Time, and that's by sharing best practices and reducing different variations of ways of working in primary care, because we're aware that not one size fits all, and someone may have a different way of working, so it's about obviously learning from one another as well. And last but not least, we recently this provider selection regime, which came into force on the 1st of January. So before, the procurements used to be quite timely, because obviously they had to go to wider competition, whereas now with the PSR that came into force, it's about removing the complexities, and it's adopting more of a flexible and pragmatic approach. So you could go out to expressions of interest, and if there's a change to the actual service specification, that's when you would perhaps go out to an open tender. So it helps us commission services a lot quicker. But as it's only just coming obviously 1st of January, we're currently working through with our procurement experts just to understand that a bit more in terms of what we can do. I know the committee asked how things have developed since obviously integrating with the ICB. For me, from working from the East Midlands primary care team, I have found the networking excellent. I absolutely enjoy it. I enjoy speaking to other people that work at that place level, so how we can change our service specifications going forward. Because at the moment, contract extensions are being extended to maintain those services, and if we do get to that point where we do recommission, at least I have that knowledge and skill set as to how we can make that service spec more tailored to that area. So that's where you get the place-based commission come from. And I'm not sure if Victoria must come in terms of the relationship and how you found things working since obviously the integration to ICBs.
Yeah, I think it's given us a real opportunity to create a different narrative around how we want to promote and support dentist activity. Recent conversation, and because I could bring a conversation that said, I know that local area where that dentist has just closed down, I understand the demographic profile, understand some of the transport issues in that area, understand some of the wider dynamics of the way that works or could work with primary care, GPs, etc. We were able to have a different level of conversation. So I think it's a real opportunity with the new arrangements in place, but we've got to allow that to mature a little bit further. It's still very early days, but I'm very optimistic about what the opportunity does bring.
Thank you very much for that comprehensive presentation, and it's really good to obviously hear how collaborative working is going, as you just touched on there, and the progress being made. So I know committee have a few questions. I've got quite a few, but I'm just going to touch on one now before opening the floor. So that's actually based on we said finally about the access to the finding your local NHS dentist. So I went on the website yesterday and put in my postcode. I rang back in the middle of my division and rang the first 3 practices that came up to say they're accepting NHS patients, and all 3 of them weren't. So I know it's like 90 days, and maybe just all those 3 there. And also, when you look on the website, the wording is only taking new NHS patients for specialist dental care by referral on quite a few of those as well. And it's just understanding. Now, to me, that's when they've gone to the doctor or to hospital and be referred. But I think just to explain a bit more on the website for patients who are looking at that, and I'm also quite concerned up into the impact going on to the GP services to actually people understanding, well, to get myself in the NHS dentist, all I'm going to do, and go to the doctor, saying, well, hopefully they'll refer me to. So what we're doing is actually putting more burden on GPs coming there. So if we might just touch on that a bit more about what more we can do to not only keep the websites more up to date, more current, because again, even after 20 people, I was getting quite a bit. And as you said, they're all very pleasant people I spoke to. It's not about, they weren't saying, we haven't go away and put the phone down. And actually, last one I spoke to actually said, we haven't been put you on a waiting list, but would you like to come in privately, and did the whole sales pitch to me as well, which again, I understand why. But again, if I was a member of the public ring up there, I feel perhaps maybe intimidating. I'm sure that I wasn't what I was trying to do. You might do a bit more bounce into that. So yeah, if you might just touch on that bit, that'd be appreciated. Thank you.
Thank you. Thank you so much for calling around. I think that's a real snapshot of the situation. And although it is mandated for the practices to update this website 90 days, the challenges that we're currently discussing is how do we ensure that that happens, and how do we ensure that that is correct information. So say at the beginning of the 90 days, they're taking on, they say, we'll put on, we're taking on. And then 3 days later, they're right, we've maxed out our limit. Now we're no longer taking on. On the website, it still says taking on patients. So that information still remains incorrect. So the current discussion that we're having is how do we ensure it's so up to date for patients? And I don't really have the answer right now, but that is something that we're discussing. What we don't want to do, I think we have discussed this, is add to the additional pressures of dentists already. So add to that, and I think that's where we're sort of finding difficulty in finding the solution. In terms of referrals only, some practices have these contracts like IMOS contracts and things like that, and that is referral only. So sometimes on their website they will say by referral basis only, and that will be under that condition. Similarly, for the child-friendly support practices, what would happen is that a referral is sent from a normal dental practice, so a general dental practice, through to the CDS, so community dental services. They would then assess that and say, actually, yes, the child needs a bit of extra care, but doesn't need to be seen by us. And then they refer to the child, or they just send it to the child-friendly support practices. So that's also a referral only contract that they would do. They wouldn't necessarily be able to just take them straight on. So that's maybe why they would be saying that. Usually, when a patient calls the GP, the practices don't usually get referrals by GPs. What tends to happen is that burden goes onto the GP services, and the GP services either have to say, I'll prescribe you antibiotics, or you need to go to hospital. So we really need to address that, because that burden is going elsewhere and it's sitting outside of the dental framework, and that is a huge issue, and we need to work with hospitals one-on-one to address that as well. In terms of private dental care, this is not uncommon, but what tends to happen is that NHS dental practices might say, we've maxed out our remit of the number of patients, or the UDAs and things like that, and therefore we can no longer take on additional patients, and that's when you get that sales pitch of, would you like to be seen privately? What we don't want to happen is that those patients who really need NHS dental care, and this is the access problem, are always pushed in that direction where they can't afford it, and they're pushed to take out their own teeth, in stories that we've all heard before as well, because they can't do that. So that's where we need to address the access issue, by either increasing the UDAs that are available for practices, or something like that, or incentivising them, and that's where flexible commissioning comes in. So there has been a document that's released nationally, and I think the commissioners and everyone's churning through that document and waiting for further clarification, is where on a local level the contracts of general dental practices can be flexed to increase the number of patients that they see, for example, from the vulnerable groups or certain groups, which sits outside of their current contract. So it can't be something that they already do, but sits outside of that, and that's where we need to look at, and that's what hopefully the next 12 months or so we'll be going in and focusing the energies on. And the important thing is that we can say all these ideas, but we need to work with the local dental practices to make sure that there's incentives for them to actually adopt those flexible commissioning as well. But Rose, do you want to add to that?
Yes, sure. So that also reflects onto what Pavni remembered about the NICE recall guidance. So about ensuring that dentists obviously recall the patients as per the guidance, and not routinely every 3 to 6 months. Otherwise, you limit that capacity for new patients being seen. And with reference to the Director of Services and saying referral only, I agree, that's not helpful at all. In fact, Pavni's colleague, the local dental network chair in Derby and Derbyshire, has escalated that to the Find a Dentist website to ask, can we have that removed or change, or the wording changed somehow, because it's not helpful to patients. And to be honest, as a commissioner, I didn't even know what that meant as well, referral only. So we had to ask that question, and now we're just currently working with us how we can make it more user friendly. So even though the information is there and it's mandated, it's about how relevant is it to the patient, and what negative impact will it have. In fact, if anything, it needs to have more of a positive impact rather than negative. And yes, it has been mandated, but like Pavni said, it's just about that balance in terms of working with the dental practices as well. But we do send the regular reminders. It is shared with the Undersecretary of State as well, and we do get regular data in terms of what has been updated, what hasn't. Our Health Watch colleagues do monitor that as well. It's not their role to do so, but they do so just so that they can help signpost patients, and it helps us as well in terms of obviously understanding what's happening on a patient level basis in terms of that patient voice.
Okay, no, thank you for that comprehensive answer. I think, by the sounds of it, you're trying to obviously get through this and to work on it. So when you do have a way forward, if you could have like a written update, which I can share the group, that'd be much appreciated on that one. So thank you very much. Councillor Eddie.
Recently, I've been having quite a few conversations with people who are involved with children's services and family hubs and things. And one of the major things that comes up is access for dentistry for children. And it was one of the major things they raised with me. I see from the report only 54.8% of children have been seen by a dentist. What more can we do? And when I speak to them, it's because they can't get access to an NHS dentist. What more can be done to encourage that? I mean, I've managed to get my daughter in, and she's been quite a few times since she was probably 18 months, 2 years. And it's such an important thing to start off while they're young. I just wondered what more can be done and what your plan is to get that percentage up, because even in 2016 it was only 61%. What percentages are you looking for?
So we recognise the challenges have always been there. It's been exacerbated by the COVID pandemic, unfortunately. With regards to increasing the access, it's about educating the general dental practitioners as well in terms of obviously how to treat children. Sometimes they have different own skill sets as well. So it's about increasing that confidence. So training, working with Health Education England as well, the Commission of Additional Services, and also the Oral Health Needs Assessment Refresh will help us in terms of targeting those higher numbers. And I know it seems like you're picking and choosing from obviously what's come out from the report, but it helps us obviously prioritise by urgency, shall we say, and then have a plan obviously for the other pockets in terms of obviously children having access. But it is ultimately about expanding that capacity. But then even if you do incentivise a dental practice to take on more activity, there's also the other challenge in terms of workforce. It's getting the workforce to obviously undertake that activity, which is why we're trying to obviously increase that skill mix as well. So obviously more clinicians can then see patients, and then that will obviously enhance that capacity in terms of adults and children being seen. But I do feel that in terms of children, I think it's more of an education side as well as the commissioning additional services. Hence why we've got the child-friendly support practices so that children are being seen and they're not obviously just being referred to CDS and increasing their waiting list. And I absolutely know where you're coming from, Councillor Eddie, because I've got 2 children myself. One's in secondary school, one's just about to go to secondary school, and I know he needs ortho. And being a commissioner and looking at the position, yes, I'm exactly the same as you guys. So yeah, it is difficult, and I'm doing the utmost I can, obviously, with the ICBs and within our limitations.
Can I come in there as well? So, completely agree with your points there. I think there are a few elements that we are trying to tackle at the same time. There is a national sort of initiative which is called First Check by One, which is about encouraging parents to take their children into the dentist by the age of 1 to have that sort of initial engagement with the dentist. And the challenge comes there is, okay, yes, they're aware of that, but they can't get in with the dentist, and that's where, like Rose has mentioned, the training, the CDS support practice and so forth comes in as well. We also have an oral health promotion team, and that is in Nottingham and Nottinghamshire now as well. And they have engagement with sort of the members of the wider healthcare workforce who go out to parents and have those early interventions, and they're doing their role to try and educate them and to train them up to allow that signposting to happen as well. They also go into schools to do oral health promotion and get that engagement and education with the children quite early on. The one other thing that we need to look at, and that is flexible commissioning, and I'm going to drive this point again and again, is hopefully the national document that we're waiting for will provide clarity where we can have these additional incentives that focus on groups such as children, such as vulnerable groups, to allow access for these groups. And I don't know, I don't have a magic wand, but I'm hoping that flexible commissioning is one tool that we can use in the foreseeable future for addressing this challenge that you're having.
Can I just add on to that as well? Sorry, get trail of thought as more things are being said. With regards to the children access, it's about ensuring that obviously the children are educated, and also because the local authority, they commission the prevention. This is where the bonus of obviously the ICB integration comes. It's about working together, more integrated care, ensuring we don't duplicate anything that they're commissioning. If they may want to commission some initiative and select some practices within the year, we can support them with that in terms of from a commissioning perspective. So that does open up obviously that hole, shall we say, and obviously help us to try and fill it in terms of obviously adding some of that prevention. So obviously it helps in terms of reducing future access in dentistry. So say, for example, a child, I went into a community dental services just so I want to understand what they do on a place basis in terms of the patient and the clinician level. And there was one child who was being assessed for 5 extractions, 2-year-old, 5 extractions. And I thought that's just awful. And that's in terms of obviously the diet, and then obviously having early extraction when it comes to them being older. For when adult teeth comes through, there's no guide. Because normally your baby teeth falls out and then the adult teeth comes through. So with having the early extraction, because there's no guide, the teeth aren't aligned, which then has an impact on orthodontics. So by bringing in this preventative measures, it helps us in terms of the future direction, in terms of dentistry for our children and their children. And I'm very passionate about that, which is why obviously it's just about working together now that obviously we're ICB integrated, and trying to obviously commission those services for the best of patients. Thank you.
Then Councillor Walsh.
Thank you, and thank you very much for that excellent presentation. It's obvious that you understand your brief and the challenges involved. I just want to drop back to one of the figures that was quoted, which was, I believe you said 619,000 annual backlog in terms of appointments. I think that figure is what you said. I just wondered on that, what methodology is used to determine that figure?
No, that's sure. That's the number across the Midlands. So that's looking at the 24-month access. So the data we have, we can look at the 24-month access in terms of recall, because obviously that was normally the recall that you normally see for adult patients coming back to a dentist. So that's what that data is based on, the 20-month recall on the access now compared to what it was at this time pre-pandemic. And so in the comparison of that data, it shows that it's about 618,410 versus pre-COVID, so roughly 619,000. But that is slowly decreasing over time, but there is a long way to go still.
Okay, brilliant, thank you. And also, subsequently, as a result, I mean, we've touched on the COVID situation a number of times throughout this. One of the discussions that I've been having with the dental prosthetic businesses is that they were struggling specifically during COVID because of obviously the appointments came to a halt, and therefore there was no business for them to be carrying out. I wondered what work involved with that has and how that's slotted into your plans moving forward. Have those businesses survived? Do you need more of those? And has that caused more of an impact as well as it's gone on in terms of delays because of those works that are needed? I assume it almost blocks a system that then keeps getting blocked and more fall, because those people can't move on. Yeah, that's it.
I think that's a very good question. I think it's quite difficult to determine, and the reason for that is that the dental laboratories sit outside of the NHS, so they might be creating NHS dentures for dental practices, but the commissioners don't have a direct link with the dental laboratories because they themselves don't hold an NHS contract. And I genuinely believe that this was a part of that challenge for dental labs because they were independent. They didn't have that support. They're seen as an independent business. So when the work stopped in NHS practices, in dental practices across the UK, they were kind of left to just try and survive. So unfortunately, I can't answer in terms of how does that fit in because I don't have that direct number. But subsequently, there's a local dental network, and we engage with stakeholders, and part of my role is to engage with dental care professionals, and part of that is dental lab technicians. And the reason that we started engaging with them is because of the pandemic. We realized that it's not really fair, it's not really acceptable to leave members of the wider dental team sort of exposed and things like that. So we are engaging with them to try and address their challenges, and there's a dental care professional network that's been set up across the East Midlands to engage with individuals. So who don't hold an NHS contract necessarily, but they are definitely part of the team that deliver the care for the patients who receive the NHS dental care. So it is an issue that we are aware of, but I'm very sorry I can't give you numbers and things like that. And in terms of the backlog, I don't know. I don't really know, because what we're not hearing that from the local dental practices, that there is a challenge, but I don't have the statistics of how many lab technicians, for example, might have left the profession and things like that. I don't know that.
Yeah, because I think it's if we just come back to it, sorry, I think it is a key connection with that specific, in supply chain terms, because you've got to, as you say, your contract is directly, with us, if you like, in terms of the public, eventually, and so it's how it has those impacts on those knock-on businesses. And I think I'm always conscious that we're always thinking about all groups of that, because all part of that chain is fundamental to its success, both on both on the NHS level and further, obviously, connected with patients. So yeah, thank you very much for that answer.
Hi, thank you. I've got my first question is, you mentioned a fifth, so I'm talking about children to start off with. Okay, a fifth of 5-year-olds, did you say, had tooth decay or been to a dentist with tooth decay? Is that what you said? A fifth?
Yes, so they experience tooth decay.
Okay. So how much is that in numbers? How much is that in how many children in Nottinghamshire have got tooth decay, to the extent of which you said? And where are they? Because this is a very genuine, a very, very serious question, because health inequalities are increasing in Nottinghamshire, without a doubt. And I would suggest those children with more tooth decay problems are some of the most poorest children in our county, and that needs dealing with urgently. Really, really urgently. What isn't the answer to correcting or helping those children is fluoride in water. And I'm not talking about the motion, I'm talking something in this report. The government received royal assent in 2022 with regards to local government making those decisions. A consultation to get that started in anywhere in the country has not even started yet. And yet we're talking about a fifth of 5-year-olds in Nottinghamshire with tooth decay to the point where there has to be intervention. And I would say, and I'd welcome the figures with regard to this, I strongly, strongly suspect that those are some of those children in the majority of them are the most poorest parts of our county, which means health inequalities with regards to tooth decay is actually increasing in Nottinghamshire. And that is shameful. And I'm not saying that that's your fault. This is the situation that we're in. And sometimes I think we just need to have a bit of reality as to what is actually going on, because it is a slippery slope when children get tooth decay. Now, so that's my first question. I would like to know what they are in number-wise. What is a fifth of 5-year-olds? How many 4-year-olds? How many 3-year-olds? How many 2-year-olds? I talk to head teachers all the time. Kids come to school and they're not brushing their teeth. They're not brushing their teeth. So that's my first point. I want to know what these are in numbers, and I would like to know where they are in this county. And if there are more in a specific part of this county, then you should know that, and we should know that, because we need to do something about that. We need to seriously do something about that in Sharpish. So that's my first point. My other point is, and this is an ongoing concern that I raise over and over again. So if you look at the graph that's on, it says page 5, it's page actually 19, but it says page 5 of 12, and you've got the graph with regards to percentage of children, young people seen by a dentist pre and post pandemic, and we see that big dip in 2021. You know, that big dip, that's a lot of children, because those children were born during the pandemic, or there will be thousands of 3-year-olds that should have had that first dentistry appointment that I can guarantee you still haven't had it because they can't get a dentist. So the question that I raise again and again, where is the post-pandemic plan for those children that are in that dip? How are we catching up with those post-pandemic children? How are we identifying them? How are we working with health visitors with regards to it? My other concern is, and I've seen this more than once, and there's one in Broxtowe. There is a dentist that openly advertises in Broxtowe that if as an adult you go as a private patient, they will take your child on as an NHS one. Now, I don't know about you, but that feels a bit wrong to me. And that is, if you drive past it, it's there for everybody to see. You come and pay for your treatment here at a private dentist, and I'll see your child as an NHS patient. How is that allowed to be when we have an NHS? I cannot fathom that at all. So again, we're looking at health inequalities, because if you can afford to pay, then you can get your child an NHS appointment. It's fundamentally wrong. It is really fundamentally wrong. Now, I believe, and we talk about it, there's a massive issue with regards to contracts. That's where the issue lies. The issue lies with regards to contracts. And we've had NHS dentists in front of us in March 2023 that told us exactly that. So I also want to know what you're doing within your roles with regards to telling government what the issues are and what those problems are and how we can resolve it. Because unless there is a change in that contract, these health inequalities that we're seeing in Nottinghamshire with regards to dentistry is just going to grow and grow and grow and grow. So we need to nip this in the bud as soon as possible, because this little dip, and even though it is going up, so there is obviously a lot of hard work going on, we're still not at pre-pandemic levels. So, according to this graph that's in here, so will it take 1, 2 years, 2 years, or 3 years? We'll get back up to those levels, but I want to know, what about all those children that haven't had that 3-year-old an appointment? Where are they, and how do we reach them? And last but not least, I do say this because this local authority is talking about introducing family hubs. And there's a real opportunity here for some linked up working, because if those family hubs are going in some of our most disadvantaged areas, you have got a lot of your audience already there, and there's a real opportunity. So as much as I could rant about why I think this has all got wrong, I'm also somebody that wants solutions, because I want the best for children in Nottinghamshire. And what I certainly don't want to continue is that the poorer, more disadvantaged children end up having a second-class health service than all the rest of the children in Nottinghamshire.
Okay, thank you. A few points there. Who wants to come in first?
Councillor Welsh, I completely agree with you on every single point that you raised, and I'll start from beginning to end. So there is the imminent issue that we're talking about for access for children, access for everyone. But your specific question is access for children. And yes, water fluoridation, which the consultation, the process, which will take a long time, will not address that imminent issue. What water fluoridation, the reason why we're talking about it is prevention and long term and things like that. So we'll park that idea for now. In terms of the imminent issue, we are acutely aware of this, and we are working with the ICB, because we're now integrated as part of that, to look at oral health promotion team going into the health and wellbeing hubs, addressing that, engaging with that population who a dentist may never have access to unless they walk through the door. So the part of the oral health promotion team is addressing that and working together with the health and wellbeing hubs. Then you've got the idea of access, and you mentioned that practice in that area. I can't comment on individual practices, but I know that if you do have issues like that, then the commissioning team and the ICB have a process which you can raise those concerns, and they will be addressed, and they are taken incredibly seriously. So I very much agree with you on that point of I don't think that's acceptable. I think that in terms of the numbers of 5-year-olds, you mentioned what about the 2-year-olds, what about the 3-year-olds, and so forth. The reason why the 5-year-old data is presented is because of the National Epidemiology Survey, which happens in 5-year-olds. So unfortunately, I can't tell you about the 3-year-olds and the 2-year-olds, and the data that I have is about 5-year-olds. In terms of the numbers, I can look at the report which was published and get back to you on exact numbers as well, within Nottingham and Nottinghamshire as well, and then we can look at that. The report that is due to come out of the Rapid Needs Assessment in March 2024, so in 2 months, will highlight the areas of deprivation, the areas of high need, and that will be used to influence the strategic plan for the local area and address the local needs. And I completely agree with you. We do not want the oral health inequalities to increase. That's complete opposite of what we want, and that's why waiting for this report and what it shows is imperative, that we direct the funds and everything like that and the energies towards the areas that need it. So I completely agree with that point as well. So I think there are 2 elements that we need to work on, is the long term and the short term, the imminent and the sustainable and preventative. In terms of the national contract, yes, it is a massive issue. There has been a statement to say it's not fit for purpose, and that was an issue stated by the government. I think what we do on a local level is the local dental committees, the local dental networks, the managed clinical networks, so the people who represent the profession do raise their concerns about this time and time again, including with the commissioners. But the other aspect is, what we're looking at is that is also going to take a long time. Changing the national contract will also take a long time, and it's not going to be overnight. So what we're trying to do is look at flexible commissioning in local areas, which we can address issues right now. And that's why I'm pushing this agenda forward. Is I appreciate that the national contract needs changing, and I think we all do here. But what can we do at a local level? And I know that Rose is very keen for lobbying to happen as well regarding the national contract. But it feels like we're both on the same side. We both have the same agreement in this, and it needs addressing. Completely agree. Rose.
Thanks, Pavni. Again, absolutely agree with everything you said. I'm really passionate in what I do. I've got about 23, 24 years of primary care experience. I've been in dentistry about 10 years, and I've not seen it as bad as this. And I think that probably is the same for every other service in terms of the pandemic, of exacerbating what was already there. And I agree with Pavni in terms of what can you do imminently. It's that oral health needs assessment we need, but as commissioners, we're trying to do what we can within our limitations with the national contract. But the flexible commissioning is about what can we do that's outside of the mandatory services that we currently do. What is different, because we can't flex their contract in something that they're already doing. So, for example, they're remunerated by UDAs, so units of dental activity. It's more attractive to commission via sessions because it's more financially attractive, but you can't change a percentage of that through flexible commissioning for a dental practice to see more patients at a higher price, because essentially they're already doing that mandatory service. So it's about thinking outside the box. What can you do? Perhaps it could be outreach. So some outreach work, obviously, for the children or for your vulnerable patients. And it's about that in terms of obviously what we need to do in terms of the oral health needs assessment, a rapid refresh, and also the information and working with the local authority. And you've mentioned the family hubs. Excellent. That is why we have obviously the ICB integration. It's about that network working. It's about how we can work together to commission as place-based services. And you mentioned about the Broxlow practice. I'm not happy with that at all. I would be happy if you could email me so that we can obviously look into that. It may be perhaps that practice has a contract that's just for NHS children, but if they've got a contract that's supposed to see all patient groups, that's against their contract and shouldn't be doing that at all. So if you can share that with us, then obviously we can take that forwards. I agree with the health inequalities. It is getting bigger, which is why the prevention is the long term, but the access is obviously the immediate, and then obviously that comes with challenges in terms of workforce, etc. So it's about what can we do to make it more attractive? How can we flex a contract? You could commission, you could throw all the money out there and commission something, but then you might not get the uptake because each dental practice might have a different workforce setting, so you might not get the uptake to take it up. With regards to lobbying to MPs, each ICB do have meetings with MPs, and this is where we ask committees such as this to lobby it to the MPs, so that obviously the MPs can then lobby to the government. But the government are more than aware, but I think more noise doesn't really hurt, does it? And they are currently working on a strategy in terms of improving access to dentistry, which is available on the government website. So the government are aware of it. So in summary, if there are any colleagues in here who know about any local initiatives that could be a open door opportunity for dentistry to be involved, or public health to improve the oral health of children or adults, please do reach out. Let us know. Reach out to the local dental network chair, who will then obviously have those conversations at that level, and then shall then obviously escalate to myself as the lead commissioner, and working with the ICB to have the service commissioned. But I absolutely hear you, Councillor Welsh, honestly. So, but no, I'm quite passionate about this job, and I want to see a change. So I, quite sadly, is why I joined the NHS. I know it's cliche saying to join the NHS to obviously commission better services for patients, but that is the truth from me, because it's about for my children and my children's children, and so that's why it's important.
Thank you for that. Such a comprehensive and response as well. Anything else you want to tell them, Michelle?
Just really thank you for your response, and just to make the point with regards to the report that you talked about that's going to be available at the end of March seems really, really important, and I would suggest we ask for that to come back here, because it is looking at where the deprivation is, where those levels are, and I think that is really, really important for us with regards to scrutiny, because we're talking about some very serious health inequalities, and I really think this needs to come back.
Thank you. Obviously, I'm more than happy to discuss that on the work programme agenda, but I agree with you, it's a really important topic, so thank you very much. Councillor Martin.
Yeah, Chair, I'm not going to go over everything because you covered quite a lot, and it was a very, very detailed report, and I'm appreciative of that. I think my biggest worry about it is the time spans, because when you look at paragraph 371, the National Dental Contract Reform changes, July 22, we're 18 months away nearly from that, and I just think about the actual time spans where people are suffering as a result of that reticence to use the contract, and the switch to private dentistry is the biggest issue I get from my residents, where it's created a clear divide between the haves and the have-nots. In December only last year, the health think tank, the Nuffield Trust, claimed that dentistry, as it is at the most perilous point for 75 years. And what you're saying is reflecting that, and I'm glad to hear you say that, because it means that your finger's on the button and you are actually doing something about it. Lack of funding. It also stated released an analysis that found the total spending for dental services was 3.1 billion, which is in 21-22, which is a 525 million annual decline since 2014. So it should be going the other way, shouldn't it? Really, and there's no wonder dentists are pushing NHS practice away. But the greatest adversarial impact on that is people who can't access an NHS dentist and can't afford to pay either. And last year, Ashfield hit the headlines. It was dubbed the dental desert, Ashfield, because only one dental practice offering NHS treatments for every 12,658 people. So there's only one practice for that many people in relation to where Ashfield is. And we've all been hearing these horror stories about people pulling the teeth out with pliers and stuff like that, and scraping the enamel off and all that. It's just not on, is it, really? So my biggest issue is, of course, at the moment, in light of the fact that the review of the dental contract could take 4 or 5 years, that's the problem. That is a real problem. Because not only is it having an adversarial impact on the kids, it's also a knock-on effect right through to adults. And of course, we know that poor dental hygiene shortens lifespan. So that's what are we going to do now? We've got the ICB. What are we going to do as a collective group get around that and educate people on how to that, because education is the root of, it's going to diminish the problem, isn't it? So I'll let you come back in a minute. But because last March, when we debated this, we established the fact that we aren't in the position to make any changes. It's only MPs that can make a difference to the dental contract. So we're going to write to all the MPs across Nottinghamshire, and I wonder if that happened and how many responded. But irrespective of that, now we've got the ICB. We need some kind of written schedule that we could give to a new government that we're going to have at the end of this year, whichever colour it is, and we need a proper written schedule of what we would like to see and how we could accelerate that dental contract process. That's where we need to be, because until we can get dental practices interested in treating NHS patients again, I think we're on a loser. And I think you're definitely agreeing with that already, and that's why the numbers have dropped in such, and it's just having a knock-on effect on health right the way across the county, not just in Nottinghamshire, across the country. So thank you, Chair.
Don't come on that.
Completely agree. And thank you for your support, actually. I think that sounds like a practical approach. We appreciate that it will take a long time in terms of the national contract, and local initiatives are incredibly imperative to look at, because whilst that takes a long time, we need to address the issues right now. And one of the concerns is which Rose mentioned, is the non-recurrent funding. So if you provide commissioning opportunities or contract opportunities for practices which are non-recurrent, the disadvantage of that is that practices cannot create a long-term strategy. They cannot see themselves as sustainable. They can't plan for the future because it's a very short-term thing. So what we need to do going forward is, and as of March 2024, looking at that document that comes out, is look at the long-term solution, not just non-recurrent funding, because practices aren't going to jump on that bandwagon. They want to know that their practice is secure financially and it's viable for them to recruit new people to deliver this care for the long term and to address the population's needs as well. So I think that's something that we need to look at on a local level. Completely appreciate the national sort of pushing as well.
Thanks, Padme. Just on the back of that, with regards to the non-recurrent activities, if that's from the dispersals, so from the contract handbacks, and the reason why we can't do them recurrently at the moment, if you do it recurrently and you go within the vicinity, I don't know, say like within 5 mile radius of the practice that terminated, if you commission it recurrently, you could essentially be replacing services permanently in somewhere where actually that need isn't highest there, it's probably highest somewhere else, which is why it's on a non-recurrent basis, in line with obviously the procurement strategy of the handback. Because with the dispersals, you may not necessarily disperse all the activity. You may be able to disperse some of them, depending on which practices have expressed an expression of interest to take on that amount of activity. So therefore, the remainder of it goes back into the bigger part, and then obviously the ones that have been commissioned, the non-recurrent ones, they will then be re-procured on a permanent basis recurrently as to where that need is to meet the needs of the population. And with regards to the contract, absolutely agree, which is where we look at the flexible commission and what can we do that's different, that's to the contract. What can we do to make that difference in terms of bridging those gaps and inequalities? How can we get the dentist to actually sign up and agree to actually take on this service for us? So it's a lot of work, and like I said, you could throw large amounts of money out there, but it's workforce, isn't it? So there's so many different nuances that come in terms of commissioning services, but it's about that integrated work and that collaboration. What do the dentists want? That's where you get the voice from the local dental committee chair. So obviously their constituents, obviously the dental practice, they'll get that feedback from there. Padme then, as the LDN chair, links in with the LDC chair to understand obviously what those challenges are, what can we do, what flexible commissioning ideas do you have, what is actually doable, and then that will be an education perspective to the general dental practice to understand actually that's the challenges that the commissioners have. And in terms of communication for the general public, meetings such as this help, as well as your stakeholder briefings, because this is live on YouTube. Patients and population can look at it and listen in to actually understand the challenges with NHS dentistry as well. So that perhaps is why the feedback from Health Watch is actually less. Not many patients are calling because probably accepting it's the norm, but actually that isn't acceptable. It shouldn't be the norm. There should be access to NHS dentistry, and I can tell you the MP letters that we get about dentistry, that hasn't stopped. We are still receiving those. So even though there's no noise from Health Watch perspective, we are still getting from MPs via the constituents as well. But any support through any colleagues, more than welcome, and also about the integration of other services, like I said as well.
I think you just hit the nub of the problem there. So you've got MPs writing to you complaining about access to dentistry, and yet they're in the position to change the contract, and the actual longevity of that process is ridiculously long. And I feel your pain, because I think it's just absolutely. But in the meantime, we've got loads of people who can't afford it and are further probably not as well educated about the process, and do also and just ignore it and leave it until it comes to the last thing, and then it's putting pressure on primary care because they turn up to hospitals with abscesses and rotten teeth and God knows what. And I think that's the educational thing in the meantime is from the ICB. But I do think the concerted effort of like ABC 10, whatever it is, the main things that you think would change the process, and you say money won't change it, but obviously private dental practice is more lucrative than NHS dentistry, isn't it?
It is in terms of private, but we have heard from our clinicians that they are seeing some dentists returning back to NHS because of the difficulties in accessing NHS dentistry since the pandemic. It provided that opportunity, shall we say, in terms of private dentistry. And because that's now kind of subsided, they're starting to see dentists actually returning back to the NHS for that stability. So there are some changes, but obviously this is information we've heard. But yeah, I guess time will tell. But like I said, it's not about the time; it's about what we can do now, which is why it's the all health needs assessment, bridging us out to what can we do immediately whilst waiting for the contract. Because we're not just going to sit back and wait for the contract, because the inequalities will be devastating at that time. So it's about what can we do now. We are obviously working hard on that. Obviously, like I said, within our limitations and what we can do.
Okay, thank you very much. So, bringing Councillor Watt, final speaker before we wrap up. Thank you, Councillor Watt.
Thank you very much. Thank you for your presentations. Enlightening, to say the least. A lot of challenges, a lot of negatives as well as positives. What concerned me most of all, that we're on about water fluoridation being the answer, and yet the country isn't doing it all over. Is it because the water companies don't want to spend the money? I don't know on this. It's a serious situation. We know the answer, and yet we're not doing it. It's absolutely incredible, that. It really is. But as I say, it's a very difficult situation. Put simply, there is still a crisis in the NHS dental care. When I was walking the streets some 30 years ago and above as a councillor, I've been doing it a long, long time, people used to say the problems that they've got, dog dirt and this, that, the other. In the last 3 or 4 years, it's changed. It went to, we can't get to see a doctor at all, but it's changed again. And it's now, we can't see a dentist. We can't get any possible option to find a dentist, which is a real problem. So what the question I'm really asking, as I say, and there is a huge problem in Hucknall, where I live. People are saying that they're getting affordable access. Getting affordable access to an NHS dentist is like finding a needle in a haystack. That's an old saying, but it's very appropriate to this situation. Can I say, you say you're going to want to prioritise, or the practitioners have to prioritise urgent dental care, vulnerable patients, including children, and those at higher risk of oral health issues. How can you do that if you haven't got the dentists to perform these problems, to perform the work? It's a very serious situation, but the question is, behind the scenes, what are you doing to get more dentists to work as NHS dentists? We know that, is it the contracts that are not acceptable? Is that the total issue? Are we getting people to train as dentists? Is there not coming forward to this situation? I'm at wit's end on the situation, because we all like to help people as much as possibly can, and at the moment we're not. Thank you, Chairman.
Thank you, Councillor Wilmot. Let's come up with a couple of points.
Thank you. So I think we've touched upon a few things that you covered, but I'd like to focus on your question around what are we doing locally for dentists, and the workforce transformation and education, so which used to be known as Health Education England and is now known as WTE, are looking at how we can incentivize the dental workforce, and not just dentists, but the dental workforce to work within this area. And part of that is also mentioned in the NHS People Plan, the NHS Interim Plan as well, and the NHS Long-Term Workforce Plan. And what I mean by that is how what they're looking at is how do we make it attractive for the dental workforce? Because it's all well and good even if we get dentists, but we need dental nurses, we need dental hygienists and dental therapists. How do we incentivize the skilled dental workforce to work within Nottingham and Nottinghamshire? And they are looking at that. Part of that was the Golden Hello scheme, which Rose can mention, and that was done in Facet Law. But the other side is when we look at what keeps people within NHS dentistry, or what keeps people within jobs, it's not just the finances. Finances is an aspect, but it's also the support, the development opportunities, and so forth. And that's where WTE come in, where they're looking at addressing those issues. The other things that they're looking at is, primary care specifically, allowing dentists training opportunities to step outside of their normal, dental practice, go into reskill or enhance their skills and come back into practice, so that they can provide more care to their patients as well. So allowing them the flexibility within their 5-day-a-week job to do that. So they are looking at methods of doing that and making sure that is financially viable for that person or individual or member of the dental team to do that. So there are methods that we are discussing. We're also looking at supporting the workforce through other ways like mentoring, peer support and things like that, which all make it more attractive to work in this area if that is provided, and so forth. So yeah, I just hand over to Rose.
And just to add on, so it's about the whole package. So say, for example, if I went for a job, actually I'm in this job, I'd want some benefits for me, for my family. So it's not just about the financial side, it's what can it do for me? How can I progress myself as well in terms of career in that job? And it's the same thing for dentists. It's about how can we make it attractive for them? Not in terms of funding, but in terms of the whole package for the health and well-being. Them as individuals, their family, their training, the development, and it's that full package which makes it attractive. That in fact, you might attract that individual to come in and work for the NHS compared to, another company, say private, who may just offer, say an hour breaks or something. I'm just picking something random out at the moment, but it's that is a whole package to what can attract those NHS dentists, and that's what WTE are currently working on. But again, that will be about the engagement with the stakeholders, dentists themselves. What is it that you want to see? Because at the moment, you don't get that clinical peer support as you would do in general medical practice. So in general medical practice, you have revalidation, where obviously your book is obviously reviewed and you're spoken to with a medical director. you don't have that in dentistry, and it's about how can we bring those in order to obviously make it more attractive for the dentist as a whole package, and that they can say, actually, I want to work in dentistry, I can get this, this, and this. It's good for me as an individual. It helps me with my family, and I can actually progress, and I can see a future in the NHS. And that's what they're trying to pinpoint. It's not an easy answer again. It's about that engagement and trying to obviously get it right, I guess, through trial and error. They'll probably publish something and then actually realise something else could be embedded into it, and that's what they'll work on. Because whenever anyone comes up with an idea or commissions anything, that's not your final product, is it? There's always room for improvement. But that's where we're at the moment in terms of obviously the workforce.
This has been a problem for a long, long time. And why hasn't a task force been put into place to professionals who are in the game for working out all these problems? Why hasn't that been put forward?
I don't think that's something that happens in about the task force. That's not something that would be for yourselves, would it? That's more national policy.
So yeah, there's the what used to be called Health Education England, which is now the Workforce Transformation. They do look at these issues, and they do work nationally, but there are local, regional teams, and I'm happy to go back to them and come back with a response. Yeah.
It's really quick, Councillor Martin.
Very quick, yeah. So there's two things actually. One is I was wondering if the dentistry might be an ideal situation to put a dental practice into, say, Kingsmill Hospital, Queen's City, just like we do with primary care units. I wonder if that might work, because if you can't get into a dentist practice, you go to that. If you can't get into a doctor's, you go to primary care at Kingsmill, and there's like a triage system through and I just wonder if that might create an emergency like hub kind of thing. The other thing is as well, when we're all from different districts and boroughs, they've all got local plans, and in each new housing estate brings new people to the area. Part of the contribution to the 106 funding is towards medical improvements in the area, and I've never seen dentistry ask for funding from that route to put extra rooms in, paper staff, paper education for their dentist practice. When you're attracting people to work in a dentist surgery, they might look at that and go, oh, there's 700 houses being built there, we could get 100 grand out of them.
I am, yes, thank you for that. That is something that has been raised to me a few times, but a part of regeneration programmes. It's never been looked at in terms of the bigger picture. So obviously you have the regeneration programme, more houses, more people live in that area, but actually the primary care services don't change. And how is it meant to obviously make it fit for purpose and to ensure that residents obviously have that access? So that is something that has been raised to me, but that's out of my remit, I'm afraid, in terms of that regeneration.
But now you're on the integrated care board, you should have a vehicle to drive that for.
Yeah, I guess looking back, when I do speak to our colleagues in ICB, I think on the point around the 106 is that's about the needs analysis that's done by the ICB to look at, does it need to happen there? And then you can safeguard land and development. So I think just that point, Councillor Martin, maybe just in those conversations you have, just say, we absolutely make sure we take full advantage of that. So thank you very much. So just want to, again, thank you very much for what you've done for your presentation today and the long and detailed and I'd say honest answers you've given us, which is what we're here for and we appreciate it. I think it's united to see from the committee saying dentistry is a place where we need to do better in terms of more places up there for our residents, because obviously we see that need is there for Nottinghamshire. Don't tell yourself the places, and I know there's still recovery after the pandemic and you're in the early stage of your contract. So again, when we get the report back in March, we can look out as we get onto our work programme later about potentially bring this back in the future to see how it's progressing with the changes made. But the fact that there are people coming back from private to NHS in terms of the dentists coming back from private to NHS is obviously really welcome. I hope that trend continues. But points made around communication I think is really key as well about how we go out to residents. And the point I made at the start and other colleagues have about actually making it clear to people exactly where they can get the services and how what we're actually doing as well to improve that for them as well. But it's really, really key. And again, the collaborative approach across the different sectors to make sure we're not putting that pressure on hospitals and GPs, or whether we just move a problem from one place to the other, which is which isn't going to solve anything, is it? So I really want to thank you again for your time today, and to the committee. I know we got quite a few actions to you, so we really appreciate if you come back and go through on those, and we'll get each of those distributed to the group, to the committee itself, and then obviously we can look at when we discuss our work programme later about how we can slot in a future report. It'd be really nice to have you back to see what we're going on there. So again, sorry.
Can I just say,
Yeah.
Chair, Councillor Wheeler, just say thank you for in terms of the cheering and obviously the care and compassion of each and every one of you in this room, because it is about working together and it's about appreciating that obviously everything is challenged and people obviously go through individual challenges as well, and yes, it is difficult and it is a difficult experience what's happening now, not just for you, maybe your friends, your family, etc. So I just want to say thank you to the chair in terms of obviously cheering and obviously everyone in the room for the care and compassion, and that in terms of obviously working together as well so that we can increase the access.
Okay, thank you very much, and thanks for coming in. And I think I'll just give a couple of minutes for the musical chairs to move around to the next team. But yeah, thank you very much again. Thank you. And if anyone wants a quick comfort break, I'll pause for a few moments till we reconvene for the next item.
shared the briefing paper earlier, but I'll run through that anyway because there's some amendments to it in the context of the updated figures we've received for the month of December, so we can actually now tell you the story for the whole of 2023, so to say. Just as a background information, we were still are the first CQC outstanding rated 111 provider in the country, and we currently are the largest 111 provider as well. Performance-wise, there's some figures in there which have always kept us at the top of the table in terms of the performance that we've delivered for the patients that call us, and I'll go through that in a little bit more detail anyway. So last year, 2023, we took almost 3.6 million calls. 3.5 million of them were answered within the 60-second benchmark, which is one of the benchmarks which was earlier introduced, and it still serves to put providers in that league table that we've put in the briefing paper. Out of the total calls that we had, almost 1/3, about 33%, needed a clinical input. Out of those 33%, we've had primary care dispositions come up. So once the assessment has been done, the patient is deemed to be needing a primary care input in about 57%. Self-care, when they were asked to sort of manage symptoms at home because it did not need to be seen by any of the other healthcare service providers, was roughly about 17.5%. ED was 4.9%, so a very small number. And ambulance dispatch was also a very small 12.4%. So this is in the context of the information that we've been able to gather since we had sent the paper originally to Noel. If I go back to the same paper we presented, it shows a breakdown in that chart of how different areas are performing in terms of how quickly calls are answered by the 111 provider. And if you see there, DHU is highlighted in green, the services that areas where we provide the services. So, for example, West Midlands, for the month of November, calls offered were 138,000. Lincolnshire was just shy of 20,000. And similarly, if we carry on, number 5 from the top is Nottinghamshire, with just over 31,000 calls offered. Almost 85% was answered within 60 seconds. The average speed to answer that call was roughly about 30 seconds. And if you compare that with what the national average was, it was 126 seconds, so over 2 minutes. And some providers taking almost 5 minutes to answer that call. Abandonment rate refers to someone who's been trying to call the 111 services, no one answers, and they put the phone down. So the system is able to pick those up as well. And we were running an abandonment rate, well, if I mention specifically about Nottinghamshire, it was 2.7%. 2.5% when the national average was about 7.2%, with some providers having 13% of their callers disconnect because no one's answered that phone. We were also asked to provide an insight into how the skill set is, the service capacities. So I'm not saying that you're not aware of how the system works, but just very briefly, call comes in, it's picked up first by someone who's not clinically trained. So it's either someone with the job designation of a health advisor or a service advisor. They go through the call depending on what symptoms the caller has or what they're asking for, with the help of a of a triage system called NHS Pathways, which is mandated by NHS England. At the end of it, it could come up with a result. We call it a disposition that you need to contact primary care, or you can manage at home, or you need to go down to ED, or it's more serious, we need an ambulance to be sent over. So to be able to facilitate that, besides the non-clinical health and service advisors, there is a clinical set mix, which includes nurses. Well, I'm using the word general with the utmost respect, but general nurses, dental nurses, mental health nurses, pharmacists. We have paramedics as well. So they're all there to try and facilitate that patient journey as quickly as possible to the right place first time. In addition to these colleagues who are in many ways the front line, there's a huge amount of support system in the background. So there's the continuous quality improvement service, which is running the audits, listening to calls if we have to see if there's any concerns identified, then try and address those. There's a training team, a huge training team, because 111 tends to be one of those services where people come and a sizable chunk actually don't stay. They use it as a springboard to then go on to other healthcare services, which is absolutely fine. But that involves a lot of training also. There's almost 8 weeks of training that goes through to a health advisor when they join before they can actually be allowed to take calls on their own. So there's a lot going on there as well. Excuse me. I've not even mentioned anything about HR and the secretarial support, so that's separate to all of this. We have put down a slight breakdown of colleagues in a chart on page number 3, where clinical was a grand total of about 440, although that number would have changed because we're always recruiting, especially in terms of the demand that winter will produce, and in the context of the new contract which we're in the middle of mobilizing at the moment, which goes live on the 9th of April, which would then be Midland-wide. So there won't be any East Midlands, West Midlands. It'll be all of Midlands, including Staffordshire. So clinical is 439. Non-clinical is just over 1,200, and then there is the support staff that go with it. We were asked to tell about the winter pressures and the planning for it. To be honest, the planning starts sometime towards the end of summer, because the workforce management teams are trying to forecast what number of calls we're expecting on the basis of what we have been receiving in the past few years, and what the trajectory is going, and how the trajectory is going. So that is then used to calculate how many people we will need to be answering those calls, and therefore the recruitment starts, or rather ramps up, more towards the late summerish. So that is then reflected in how we perform towards the thick of the winter, so to say. Well, we can't foresee sometimes when things like strep A outbreaks happen, but this year, for example, excuse me, when, between 19th of December and 1st of January, service level refers to how many calls got answered within 60 seconds by a provider. The national service level, which is an average of all the providers across the country, was almost 66.5%, when DHU was achieving 85%. And especially on key dates when a lot of the other support services would not be functioning. So 25th of December, for example, we had about 9,500 calls offered on that day, with a service level of 97%. 26th of December was over 15,000 calls with a service level of 99.8%. 1st January was just over 14,000 with a service level of 99%. By the way, these are not the maximum calls we've ever had. During this time period, we've hit close to 18,000 calls being offered on a day across the patch that we cover. And sometimes we'll have calls that spill over from other parts of the country as well, because the providers there might have gone into contingency, which is when maybe the systems have gone down and calls are then transferred over to us. So that is a bit of a, in a nutshell, sort of flavor of what we're doing. But we're very happy to take any questions or any clarifications around anything we've put down here.
Okay, well, thank you very much for the presentation. I mean, I have to be honest, I'm quite disappointed overall because the whole point of the item is to review the service performance in Nottinghamshire, and of course you've got comparison, and I get that, and look at the figures and how good we are compared to other places, but there's no breakdown in terms of Nottinghamshire itself to look at the response from various parts of Nottinghamshire. Because we have issues where, not to say issues, but we've got different disparity in the region of Nottinghamshire itself in terms of the services there. So I want to see that knock-on impact on those other services, for example, Newark Hospital, and we'll be discussing, but also with the data itself, it's obviously part of the picture, as you attest to yourself, where the ultimate for me is how many people are actually getting their issue resolved. So the callback they're getting from provider, whether it's it's in an hour from the 111, if it's within 10 hours, 11 hours, actually understand to make sure we are helping that person, not just the initial call, because the initial call is absolutely critical. And obviously, I see your performance there and how good we are compared to the other areas, which is obviously fantastic. However, the breakdown itself is quite disappointing. And obviously, I know that Noel did come to you to ask for more information, and it wasn't easily to get to. And we've got issues around the performance of people going to the website, the app, and because not everyone calls now, obviously, especially with the current age we're in. So that's what we'd like to see a bit more of. Or I would like to. I'd like to up to members of the committee to decide upon. So in terms of those figures itself, as a breakdown, how easy is that for you to get to us to? I mean, I know we're not going to have this meeting now, but for future, actually look down in terms of, so we look at places like by district, so Rushcliffe, Newark, to break down to those sort of areas, to Mansfield, Ashfield, all our districts, actually look at these figures broken down to see if there is a disparity between various areas. In terms of your call data, how easy is that for you to get put together?
I'll try and help with that one. So it's certainly something we can take away and have a look at. As we don't commission it, I guess, on that level, that's why colleagues will find it harder to have kind of answered that question within kind of a few days of being here, because the reports we ask for are very much at the county level, because that's the level at which we commission the service. That's not to say we can't look at that breakdown, certainly, because I'm guessing we'll have patient postcode. So if we would have to drill down to kind of patient level to be able to have a look at that data, but that's certainly something we could take away and explore. It's not something we as commissioners have at hand, say, because of the level at which we commission the service.
Well, we can obviously break it down by region, so Nottinghamshire, Lincolnshire, etc., etc. We can then break it down via GP surgeries.
Okay.
But I've never seen any data broken down in any other form. And even for the purpose of GP surgeries, we do have to ask our BI team to break it down that way, because the reports are set up so county-wise. So and as far as we're concerned, it doesn't matter where the call comes up for us, whether it could be West Country, it could be Nottinghamshire, Leicestershire, it doesn't matter. Even though we've got 4 call centres, it's the next call that gets picked up anyway. We could provide data in terms of GP surgery wise, so maybe 5 GP surgeries. If these are in a district, we can give some figures for that area. But I have to say, Councillor Wheeler, I've never seen data sort of broken down in that format.
Okay. The point I'm trying to make is I'm absolutely sure of course your team will take the next call that comes to it, but my concern is people in parts of Nottinghamshire, if they are accessing the service, because it might be that we've not communicated enough to an area of Nottinghamshire that they know to ring 111, so they might be waiting to either going to A&E or they're waiting to try and get GP1, not knowing whether to ring 111 and try diagnose that way. They're ringing 999 instead. So that's the concern we're trying to make sure, because if there is a massive disparity within Nottinghamshire, that shows that there's got to be more work done to communicate and encourage people to use the 111 service, or find out why they're not, so we can try and understand. Because my biggest concern is that people, like I say, the pressure on the other parts of the NHS, or that they are not getting treatment because they think there's no one out there for them, which is the one to get to. So I'll open to colleagues first and come back and see if everyone else agrees with me. It might just be me on this one, so I want to make sure everyone would welcome that data as well, and we'll come back to that in a minute. So I think Michelle, Councillor Walsh, had you next. Thank you.
Hiya. It's on a similar track. First of all, I think you have an incredibly difficult job, because every time I go on Twitter or every time I go on Facebook or you see a billboard, the answer to the issues in A&E is always you. And that's a problem. I think it's a massive, massive problem. So the winter pressures in A&E, the answer is phone 111. And that's a huge amount of pressure on you as a service. And I just want to say, before I say the next bit, that I fully recognise that. I'm just going to start with children. I do agree with what you're saying. I'm just going to expand a little bit on that. I just want to start with regards to the things that I pick up with regards to children. When a child gets ill post 6:30 in the evening, it becomes a jungle for people in Nottinghamshire, for the most part. When your child's temperature hits 42 and you go on the NHS 11 app, it is honestly a real, what do you do? You know, which way do you turn? You've given the Calpol, you've combined it with the ibuprofen and whatever, and it's still not there. Where do you go? What do you do? There have been situations, and this is the bit where the data, which I think is really, really important and absolutely crucial, is you answer the phone within 60 seconds to me and my child's got a temperature of 42, and the chances are what you're going to say is make sure they've had the Calpol, and I will get a call back. So the data I want to know is how long is that call back, and then what is the result of that call back? Because when my child had a temperature of 42, I've sometimes got a call back, sometimes I didn't get a call back, and the times that I have had a call back, they've said go straight to A&E. Okay? That's not what it says when you're looking at where they're directing you to go. It doesn't tell you to go directly to A&E. So some of the data that I really would be interested to know, and I've raised these concerns, and actually it was battered back at the last Scrutiny committee that everything was fine with what was happening with regards to this. The data I want to know is what happens once you've taken that call. So once you've answered that call in 60 seconds, what then happens after that? How long does it take to get the call back? What happens with regards to children? What happens with regards to elderly people? And I think this is important for a number of reasons. One, I think it's really important for the care of people, but I also think it's really important for you as a service. Because if the services aren't there for you to direct people at, everyone's going to point the finger at you. So it doesn't matter how quick you answer the phone after 60 seconds. If you answer after 60 seconds and 3 hours later, I've been told what I thought I should have done 3 hours ago, which is take your A&E. But if you look on Facebook, it's telling me not to do that because the ACB is telling me not to do that. Then that gets me frustrated with NHS 111. And I don't think that's necessarily fair. But I do think we need to have that data. I really, really do. And I think we need to have that data because I think it should influence the way you commission. I'm shocked that you're telling me that the level in which you commission this service isn't broken down by area in Nottinghamshire, given to the endless conversations that we have with regards to health inequalities. Because our prediction is you should be collecting that data. And the reason you should be collecting that data is to feed back to everybody else in health where that greater need is. Are there more parents with children phoning up in, I don't know, I'm saying Gedling because that's where I'm, or Sherwood or Ashford or Broxtowe? Where are those issues that get back. So just going back as well to what Councillor Wheeler was saying, and I don't think this is deliberate, by the way, but this isn't the usual type of level of detail of report that we would expect to get here in Scrutiny. So we would actually expect greater detail, and maybe some of that is explained to us why that detail isn't there or why it perhaps doesn't exist. So there are things that I think would be really useful for us to know, and I don't know if you can get this information or not, and this is what we're using. How many of them callbacks are you directing straight to A&E? How many get a call back within an hour? How many get a call back within 2 hours? How many don't get a call back until the morning? How many times is it, right, you just need to phone an ambulance? Because I think the effectiveness of 111 is equally as important as how quick it takes for you to answer the phone. Does that make sense? And I think actually this is about everyone not pointing your fingers at what I'm guilty of. I'll admit that I am guilty of it at times when I've 111. Actually, it's not 111. It's that bit after 111 that's failed. You've done the right thing. You've said I need a call back. Yeah, a call back from a doctor or whatever, but it's not happened within that time frame. And so there's this frustration. So I think Councillor Wheeler is right. There's a whole level of information that for us as a scrutiny team would be really, really useful. So things like how do you monitor as a commissioner? How do you monitor what the callbacks are like and what that time frame is, and what is that for Nottinghamshire? How quickly does that happen? How do you grade things as well? Would be really useful to know. For example, I know if I was to phone up and say a temperature of 42, it would be dealt with in less of a time, longer than if it was my son. My son when he was, I think it was 6 months old or younger. It's a certain time frame, and then it goes up. Well, that would be really useful for us to know. And just to go back, so I'm sorry, I'm really confused about all of this. What we need to know is as well, is this here all the data you have with regards to 111 service? And you're saying, well, we could break it down by doctor's surgery. That concerns me a bit, because I don't think that's helpful to health planning in Nottinghamshire, and I don't think it's helpful for you as a service. I really, really don't. As I said, I think there needs to be a level of monitoring that goes as deep as how many people contact our children with temperatures, how many people contact with regards to dentistry. Where is that need? Because you are absolutely critical in identifying need across Nottinghamshire. Absolutely critical, because you are such a valuable service and people fundamentally rely on you. So it's that level of data that's not here. Councillor Wheeler has asked for some of it. I'm not criticising the report is in front of me necessarily, but what I would say, this isn't the level of information that we would usually expect. And I'm not talking on behalf of from a personal level. It's very hard for me to go away from this meeting saying whether NHS 111 is meeting the needs of people in Nottinghamshire. I hope that.
Yeah, thank you, Councillor Walsh. I know we're saying points. I think I should also say as well, I know it's the first time for me as well, so I know it's the first time looking at how we accept the reports, and I accept maybe we could look at more how we communicate to make sure that level of detail. I think it's completely right in terms of what Councillor Walsh has said in terms of that breakdown, because I know, and points especially at GP practice, and I completely agree with the point made there that it doesn't get that full picture, because you are the front door, so to speak, of that. And people ring you first there, and triaging, for a want of a better phrase, probably more accurate into the sector we are. But to understand how we can not only help you, but also understand what issues might be across the rest of the healthcare in Nottinghamshire, because that's where that data is absolutely crucial, as Councillor Walsh says. That's where we're trying to get to. That's why I understand that, because if you're saying sometimes go, which they are, there might be a false impression, everything's great 111, it's brilliant, let's just keep it as it is, whereas it might not be, because, as we said, in certain areas they're not accessing, or you're getting 100,000 people ring you because they can't find a dentist, which is up to our previous items. So then we know, hang on a minute, we need to get that feedback back to the dentistry team to go, you're causing a lot of calls here because they can't find a dentist, so you need to be working together to stop that. It's a bit more deep. Does that explain hopefully a bit more? But if you'd like to come back and we'll Councillor Walsh's points, I appreciate it. Thank you. I don't think you want to come in first.
Can I just on a couple of points to see if it helps explain what I was saying about us commissioning at a county level and your concerns about that, which I completely understand. And I think that goes back to Dr. Sharma's point in that we commission them and it's, to all intents and purposes, kind of a call handling service to route people into the right service. So we do commission at a county level based on historic activity levels that we monitor all the time. So we wouldn't commission at a more local level because essentially it's going through to a call centre. So it's about them being able, having enough staff to handle all those calls. I think the point you've picked up, which is the crux of it, is then what services those patients are going on to, which pathways they're ending up in, which I think is the interesting breakdown you're probably after. So I don't think it's necessarily how we commission the 111 end of it and making sure we're doing that in an equitable way. I think it's then what needs there are. Appreciating we might have pockets of areas that don't use 111 as much, and I think that would be a really interesting piece of work to do to understand how our patch uses or doesn't use it differently. The way we look at that at the moment is DHU give us the activities we've discussed via GP practice, so that's at the minute how we understand if we've got pockets of areas across the county that are using it a lot, not using it so much, so that's kind of how we look at that at the moment. And then the question you had around why is it different if you phone up with a temperature of kind of 42 versus a child of 42, and that comes back to NHS pathways that want a mandated.
Sorry, to stop you. That wasn't my question. What I was saying is that kind of information would be very useful. I know why. I know the NHS pathways. I'm saying that kind of information in a report in order for us to scrutinise with regards to 111 would have been very useful in the report for us to see and with regards to a public document. I certainly wasn't also criticising your commissioning on a county level. What I was saying is when we said can we have it per area, you said you don't commission in that way. I was saying people in the south of Nottinghamshire live 7.5 years longer than those in the north of Nottinghamshire. It is critical that we analyse health inequalities, and the 111 service is absolutely critical with regards to how those services develop in the future. So my question was with regards to commissioning, what is your billboard doing with regards to what's coming through with 111 and feeding it back to ensure services are more equitable around the county, and if there's more need that we get that need part of that bigger picture was my point. I wasn't criticising the way you commission it, if that makes sense.
I think it's just us unravelling that layer below the 111 data, how it links definitely. I think it's that level below to understand the pathways and those service needs at that level. So yeah, completely appreciate that.
Yeah, just to say, Councillor Walsh, I absolutely do acknowledge and hear the comments that you've said. And I think there might be an opportunity for us to reflect on that, particularly in bringing any future report back, which will offer a high level of granularity. You're absolutely right. If we don't understand what the activity is and what's driving some of that, how can we put the appropriate plans in place to address those inequalities across the system? So, and that is absolutely top of our priority and our commitment to do that. And again, I'll go on to that's what supported by place-based partnership working as well. So hear the thoughts that you've shared with us, and thank you for that. And we will definitely take them on board for the next report. Thank you.
Yeah, in the past, the NHS, so I presume you're from the NHS, because I can't see what it says on you. In the past, the NHS did a poster programme directing the public. So also as well, the information would be reciprocated in how you direct that, because directing the public, especially in Nottinghamshire when we had a critical incident over the Christmas period because of inundation in the workforce and strikes and etc. But it was a very clear format. It was about 2016, I think, and they did a very clear poster, very simple, social media usable poster, because we are the ideal conduit to send that out through the county council across the county to direct people to the correct services, which could cut down the number of calls in the first place, because you use the right service the first time, that kind of thing. And we don't see a lot of that coming from the NHS, and when they do it, it's rather dull and flat. It's not very interesting. It doesn't make me think, oh, I better go to A&E, oh, I better ring 111. You know, there's always loads of literature on it. It's too much. It's got to be simpler. And I think I know that sounds terrible to say that, but it's true. Because, you know, if somebody's reading it for longer than 5 seconds, they lose interest. But that would help the NHS generally across the hospitals, A&E, doctors' practices. And my actual initial question before everybody started was, you know, could you give me the information on how many people have rung 111 wanting extra dental care? That was my main question, because in light of what we've just been talking about, you know, so that level of information would be great. But also it helps you to direct your advertising campaign nationally, not just Nottinghamshire, nationally, in the right direction to get the public to use the right service at the right time the first time, because that would save a lot of time. Thank you.
Yeah, and I think we can feed some of that back to the national team in terms of the comms, because we are limited locally, which can be a bit frustrating in terms of the comms we put out for things like 111, because it's nationally mandated. We have to take the comms that come for the entire country, so we're a bit limited as to how we can tailor it locally. Although we try and get away with what we can that we think suits our population, but a lot of that is driven centrally, and we're given the materials, so we do feedback if we don't think they'll quite work, and more than happy to take your feedback as well, that perhaps they're not always necessarily working for the public, because we do have those conversations with the central comms team, so we can do that, and we try where we can to shape what comes down.
Yeah, I'll just give you a typical example. When the NHS in Nottingham declared an emergency incident, you clicked on a link onto there, and it brought up more pages than I've got in this agenda here. Nobody's going to read that. When they click on that link, if they're being directed to another service because you don't want them to come to hospital, it's got to be a simple thing, and it's just far too much. And the NHS are always guilty of it. You know, I don't know who the hell invents their posters of God knows what, but they've never looked at social media, and they must come from China or somewhere, because you just write far too much. And it's too complicated. It's far too complicated, because in an emergency you want to get the right service at the right time. And anyway, I'm going on now.
Thanks. That's great. So, Councillor McGrath.
That was basically what I was saying. Is Councillor Martin brought it up, is on your callbacks, because obviously you direct people, don't you? But you said abandonment was at 3% in Nottinghamshire. Unless my maths are wrong, and I'm not very good at maths, that works out nearly 3,000 people that you haven't recontacted over your figures. That concerns me, because people all panic, right? They won't know what to do. You as a service, or NHS as a service, haven't rang them back. So I think we need to implement what we do with the people that we don't, as I say, get hold of, because it can be a worry as well. Really, please.
No, quite valid points, and I've been scribbling as you know we've been mentioning things. If I may start first with Councillor McGrath. So 3,000 calls. It's not always that we've not been able to get to them and therefore they've disconnected, because we're answering a call within 60 seconds. So the system is able to pick up that Mr. Jones called us, or rather the telephone number comes up. But in terms of trying to call them back, that's difficult, because it may be that they don't want to call the 111 service. That is why they're disconnected rather than hanging on onto the phone, and therefore, oh, no one's answering, I'm going to put this call down now. We've never had situations where, because significant events get discussed. You know, for example, if Mr. Jones actually had a heart attack, waiting for us to answer that call, and you know, ambulances were called, etc., and they say, well, I called 111, no one answered. So that gets picked up and that gets discussed in the clinical governance meeting, which I chair and Susan is with me. We've never had any instance where someone said, I called and you didn't answer. If at all, it's the other way around, that we've, because we are 24/7 service. Someone calls us at 10 p.m. And that links in with what Councillor Welch was saying as well. Every call that comes in and it gets triaged, it then reaches a level of acuity, as in the really serious ones. So someone maybe a high temperature, child, elderly, someone needing palliative care, they wouldn't be waiting bottom of the pile from that first conduit from where we are diverging those calls. So they would be considered high priority. So there'll be more clinical resource to get to them quickly, as compared to someone who's saying, well, I'm going to run out of my tablets tomorrow, and it's a Sunday, so I'm calling to get a repeat prescription, because we get those as well. It shouldn't come to us, which links into what you were saying. I'm not here to shoot anyone down, but a bulk of our work is prescriptions, dental, and refused GP disposition, primary care dispositions. So we've triaged the call. I'm going to use another example, shoulder pain. I've got shoulder pain, I've called my GP, they said I haven't got an appointment, or I've been on the phone, I haven't been able to get through to them. But because they know we will answer that call in a few seconds, and coming back to what Councillor Wheeler was saying, we don't need more advertisement. That calls are really going up like this. So those calls will get answered, which is why they call us, and to a degree we're happy they're calling us, because that's what we're there for. But in many ways, then we're having to keep running to stand still, because those calls have been shooting up. When I initially prepared that paper, that was really on the basis of 2022 figures. That was 2.5 million. 23 figures are actually 3.5 million. So we're very happy to deal with whatever comes to us, but some of the frustration we have is that we're not the right service for them. We can tell them, look, we think you need X, Y, Z, but then it's a case of, well, I've already tried, I can't get to them. Okay, so that means a clinician has to get involved to say, okay, well, let's try this, that, or the other, but eventually we'll have to go and see them. But that's the negotiation that then happens, or trying to get them to understand or appreciate the situation that's in front of us, that we're really sorry we can't do this. We feed this regularly in terms of refused primary care dispositions, requests for medications, which really shouldn't be coming to us. And the ICB colleagues always put a renewed focus, especially before Christmas, New Year times, or Easter holidays, etc. Communications go out to GP surgeries as well, saying, look, order your prescriptions in advance. And they are more than happy to give an extra supply, rather than saying, well, you're not due for it yet, but so call us later, but then by then it's too late. We have pharmacists as well who are able to help out when we can. So it's not always a case of, well, it's pharmacy, we can't do anything for you now, call them on Monday. So we do try and deal with it as much as we can. Now, also going back to some of the other things, Councillor Welch, under fives get a high priority outcome anyway. So anyone calling under 5, unless it's absolutely certain that they had fever, it's gone down, and they're eating and drinking normally, no cough, no cold, was grandma had a chest infection, so they might have picked it up, a virus. Unless there's absolutely zero concern, they will get picked up by a clinician. So extremes of ages, the very young and the elderly, we put them in a category where they get a clinical callback. So we do have kind of the way we put our queues in. So priority 1 is the most urgent one, so they will get this, as compared to someone else who, once pathway has been used to triage them, and it says, well, you need to see a GP in 12 hours. That is clearly less urgent than someone that says, speak to primary care within 1 hour. So that is how we divide the calls when once pathways has gone through. Dental activity, yes, we can get that. It's not a problem. In fact, we do regularly feed that data. Again, as Councillor Welsh was saying, is that the only way data can be presented? No, it can be presented by age. It can be presented by symptoms. So how many people with back pain called us, etc. So we can do that. But for us to do that, if you say like we need it this way, no problem, we can do it. As you said earlier, we've never been in a meeting like this, so we didn't know what was expected of us. But this is how we've normally been feeding it. Now, in terms of age-wise distribution, symptom-wise distribution, we use it in the clinical team to look at our pathways or how we are managing those patients when they're calling us. But it's for help me if I'm mistaken here, but for the commissioning purposes, it's more of a overall picture in this format that's been presented. But as I said, we can break it down. It's not a problem.
And that we appreciate. I think it's worth saying, because we've already heard from our friends already, the amount of what you're doing. You talk about 3.5 million calls. It's a huge jump, obviously, in 2022. It's understanding why that is. That's what we want to understand. Because I say, if it's because you've been pushed, I mean, give an example. When the NUH had their critical emergency, obviously everything was saying everywhere, ring 111, or they're going there. So of course, I imagine the spike was pretty very few cells there, potentially because that's what everyone was being told to do. But also, like you say, if it's just the fact of because people can't get into a GP in a certain part of Nottinghamshire, that's why they're ringing 111. We need to know that so we can have the discussion. So maybe that gives me more detail. But I mean, judged by that data you got and the amount of what you're doing, it's absolutely fantastic, and that's great there. But what is also important is to communicate. It's about advertising ring 111, but it's about actually communicating to the public actually the work you're doing, but actually also to help educate them in terms of when it's right to ring 111, when it's right to go to A&E, because that's what we want to do is people who generally need to go A&E go, no, I've been told not to, I'll sit here and ring 111, when actually, so that's what I said, if you knew earlier, if you're an example of a child there to go down A&E earlier, obviously that can be life and death as we know, so that's to get to, but also we'll cover that with more detail at the end once someone's come in, but thank you for that. So Councillor, are you okay with that point?
Yeah, I'm okay with that. Thank you, Chair.
Okay, Councillor, I know you said your point been covered, so thank you very much. So bring Councillor Eddie, and then it'll be over to who we've got next on there, Councillor Wilmot after that. Yeah.
I don't think a meeting goes by here where we don't talk about 111, and I've made a couple of notes. So when we had the GP services in, it was, you can ring 111 and you get an appointment with the GP. At hospital, when it's closed, you can ring 111. EMAS, I think, mentioned 111. I think every person that's come in has said ring 111 for something. So what I think for me, I like data. So I would really like, one of my family members has had to ring this weekend and she got a call back within 6 hours. But I think I'd also like to know when people ring. So for me, a breakdown of hours. So for example, in Newark, if the urgent treatment centre opened, if we have a call from 10 o'clock at night, for me, that data would be really interesting to see, because like Councillor Welsh, I've got a little one, and they tend to always get poorly at a weekend or in an evening. It just seems to be when they get poorly. So it would just be really interesting, a breakdown of when people ring and the times, and also how long it takes for them to be triaged. I know, it was during COVID, so it's probably a bit different then, but it took 10 hours for me to get a call back at the beginning of COVID. But for me, if we had a breakdown of how many people call per hour and the times they then wait to get a call back, would be really helpful to determine where the services are. But like I say, every single group of people that come and present to us, 111 is mentioned as a service, as a backup to them. So thank you for all that you do, because it must be, it seems such a big thing. But I think data-wise, it would just be really, to get a bigger picture, it would be much more helpful, I think, next time.
Thank you. Yeah. Anything you want to add on that? I think that's... Yeah, of course.
Very briefly, we can break it down by the hour of the day. And dare I say, at the BI team Crumley, we could even break it down further. But hour of the day, no problem. I can tell you that we see our peaks, especially whether it's non-clinical or clinical peaks, they seem to tie in very, very well with around 9-10 o'clock in the morning. So, and the usual offload we get from the patients is, from our callers is, I've had the GP surgery, I can't get an appointment, or I was number 29 in the queue, and then I couldn't hold on any longer, so I've called you. So we see our peaks starting, so we see two peaks in 24 hours. One is roughly around 10 o'clock-ish, 10, 11 in the morning, and the other tends to be 5, 6 o'clock, which is when they might have been able to get through to the surgery. And I'm a GP, I'm not shooting GPs down here. When they might have called the GP surgery, being told, yeah, someone will call you back. Someone called them back, but we can't see you today. Can you call us tomorrow, or we can book you in after 4 days, whatever it might be. And that's when they say, well, I'm going to call 111. So we see two peaks. That's one thing. Second, pre-COVID, we had a weekend sort of profile of what people were calling us, what kind of issues they were calling us. Now it's the whole week is equal in terms of the days. There's no breakdown. So that's the shift that we've seen post-COVID in this. It's not my remit to pass judgment on that one, but that is what we see. And because we're answering a call in 60 seconds or less, actually, patients do say to us, quite frankly, I know my call would have got answered, so I've called you. So they go through the triage, and we say, oh, for your shoulder pain of 3 months, you actually need to see your GP. And that's when the refused disposition comes. Well, I've already tried, I can't get through. Okay, one of our clinicians will call you back. That comes into the clinician queue, and then the clinicians have to call back and explain why the disposition was what it was, and why we can't do anything about this, and why it's not good to go down to ED or call the ambulance, etc. And that increases our workload, because we've already done the initial bit to say, yeah, you need to see primary care, but then is the negotiation that happens afterwards, which is extra. Really, ideally, we could do without that. And actually, someone who had chest pain and needed our input, we'd rather get to that person first, as compared to having to say, well, sorry, but you need to access XYZ. And that happens regularly. We've got dental nurses every single day on the call center because of refused dental dispositions. And it is what it is. So, we can't turn anyone down. So, and when you pick up the call, you don't know what they're calling about. So it is what it is.
Yes, mate. And I think that's the one important rate, having that data down then helps us to help you in that sense. So that's what we're here to, not here to, want to work with you and trying to help you and ultimately help people in Nottinghamshire to get the service they need. So thank you very much for that. So Councillor Wilmot.
First of all, can I congratulate you on your 5th position in the best service in the country. I think that's very commendable. But there are just a few issues and a couple of questions that I would like to ask you. I just wondered whether you believe that all residents are now used to calling the NHS 111. Some residents, I do know, still call 999 when it should be a 1111. They call their local GP surgeries. A number of times, the one that I'm attached to says he gets quite a lot of questions that really it should be 111 situation. And some people obviously present themselves to the NHS hospitals and so forth without going to the 111. I just wondered what communication work has been undertaken to ensure that residents do understand that this number is for non-urgent NHS issues. I wonder if you've done any work on that. That's the first question. The second question is, I'm just looking at the breakdown of your staffing numbers. Clinical 25%, non-clinical 71%. Does that mean when a person rings the 111 who has a small clinical issue, might get a non-clinical answer to the situation. And how do you deal with that? Because there's nobody. Everybody hates having to be saying, "Well, I'll ring you back to do this, do that, do the other." You know, it's a problem that and people sometimes, if you don't get the right answer first time, they forget it, and then it could be a clinical problem for the doctors rather than just an assumption of what's happening. Those couple of questions I'd love for you to ask.
Shall I pick up the comms one first? So in terms of the comms, I think you make a very good point, and a conundrum for all of us trying to commission urgent care services is how we get messages to different areas, different populations with different needs in a way that works for them to ensure they're accessing the service they need first time is what we're always trying to aim to do. So we work very closely with our comms colleagues about how we get those messages out, be that messages in times of critical incident, which we've spoken about, or just generally this is how to contact the right service. And we use a lot of data. We've worked with other areas, other ICBs, other counties to understand how our populations behave and the best way to kind of communicate with them. So wherever possible, we try and tailor the comms and use various different means in different localities to try and suit that purpose. But I think you're right in that people sometimes do make the wrong choice or may not know what is the right choice. Some of that is based on experience they've had. We talk about people often go through the path of no resistance, won't they? So if they've had an experience that worked before, they'll do it again. Even if it might not be the right one, it worked for them, they'll do it again. So it's a difficult area, but when we're continually trying to hone down how we improve and make those comms. And I think picking up on the point about COVID as well and how 111 has changed. During COVID, there was very much a push, and as commissioners, we were asked to push what was referred to as 111 first. So very much making 111 the first point of contact for everything urgent, so that then people could be signposted, which I think is some of the growth we've seen and continue to see post-COVID, because we're still being asked to kind of push those messages. The complexity then comes, do the public understand the difference between urgent, non-urgent, urgent, emergency? And that's where we often get, obviously, people making those choices that perhaps aren't always the most appropriate. But I think that was the NHS England aim, that if we route as many people as we can through 111, they can then make that decision with clinical support to get somebody on the right pathway quicker, especially if people are just confused about where do I go. But there is certainly more work to do on the comms, and we continue to use as much population health data as we can to work out the best ways to do that, and working with colleagues. But continues to be work in progress to understand the best way to do that.
Yeah.
Noticed that pressed my button. Yes, I thought about it. Really interesting point. Thank you for raising. And I'm not entirely sure that all the population do know, as we've discussed. And we've got some people that will call us 3 or 4 times a day. And we listened to a call the other day from an elderly lady who was ever so sorry to bother us, because it's just not the norm for her to reach out for help. 25% of our calls are urgent or emergency, so we get 111 calls and 999 calls. So out of 1 in 4 callers really do need ED or an ambulance disposition. So that might indicate A, people aren't sure, or people really want to be cautious and not bother the ambulance service. Hence why the very first questions in your NHS pathways, which are non-clinical, are those emergency questions. So sometimes people are a little bit shocked when they're ringing with a sore throat that they're asked about their breathing and have they had a heavy blood loss. But it's really important that we ask those questions first. Some people think we're 101 as well, so we sometimes get police questions in there, a lesser proportion. In terms of people getting a non-clinical answer, Our health advisors, they are non-clinical. That said, as I moved into DHU, I previously worked for NHS 111 with Yorkshire Ambulance Service, but I decided to do some reverse mentoring and actually did the training that our health advisors do. I'm an intensive care nurse by background, and that training is intense, very, very intense, and they are audited to within an inch of their life. They have an audit each month. They have one that's side by side, so live, and then because all calls are recorded, they are audited afterwards in retrospect too. And they must have at least a 90% pass rate or their performance managed. So it's a tough job. And if we think that these health advisors are non-clinical, we understand from what Councillor Eddie was saying, we very much understand the frustration within the urgent care system. And they are a faceless person at the end of the phone. They do get quite a lot of hammer, especially when we have that scenario where we've had a person call the GP, not be able to get an appointment, go through the whole rigmarole of an NHS pathways assessment, only to be met with another disposition that's a GP appointment. They've got really good communication skills to be able to negotiate that. And because that is quite an intense labour job, and there's an emotional toll to it as well, we do get high attrition within our health advisors, and that's why we are constantly training. Some absolutely love it, and as Dr. Sharma said, go on and use it as a springboard to a healthcare career because they have gained so much information. But it's important to say that at any time within that health assessment that they undertake, they have access to a clinical line. They can get clinical advice within seconds, and they have got certain circumstances that they must do that. So if the person or patient has declared that they've got a medical condition, a long-standing condition that may need a more nuanced assessment, they can what we call early exit the case and flag it for a clinician straight away, or we can what we call warm transfer straight to a clinician. Otherwise, they can follow the end of the pathway, which may tell them to get clinical advice anyway. NHS pathways changes regularly. I think pre-pandemic we used to get an update every 6 months. Now it seems that that's every 12 weeks. The whole system is updated because of new clinical evidence that comes to light and new pathways that are developed by the boffins in NHS Digital, the professors that are learning from cases that we feed back to them. So if we think that a pathway, because we've had an incident raised, isn't quite nuanced enough to differentiate between a serious clinical need and a not serious clinical need, we feed that information back, and NHS Digital reassess that pathway and may add certain questions within there or take certain questions out should that pose a risk. And in terms of comms, we have the national comms, but we also have local comms. DHU do their own comms on all social media platforms, etc., etc. And actually, NHSE liked ours so much that they took our one just recently for the winter pressures. And I wanted just to highlight as well, in terms of the non-clinical and clinical aspect. I think it was a Nottinghamshire baby. We recently had a call where a health advisor actually delivered a baby over the phone. So, we do get everything that 999 get as well as 111. So, just to add a bit more context, sorry.
No, thank you for that. And I think that's the reason to ask, because if you have, well, as you said before, if you're ringing you instead of 999 because scared, but that extra delay could be obviously crucial, as we know, as I said, for life and death, it's understanding that how we can better communicate. Because again, when you ring 999, it's what's your emergency, and that can also sometimes you go, I don't know if it's an emergency, because like you say, suddenly being stereotypical, the older generation, they can lose a leg and it's not an emergency. We've got the spirit, we keep going to the bitter end. So it's that generational shift as well. That's why with the age, it would help us to obviously really understand that to explain. And I remember my granddad, that's the, they would never ring, as you have to, force them into hospital, and even they didn't want to go. Now I'm fine, but so I completely, that call you had from your safe elderly lady, I imagine she was probably embarrassed to ring you, even though she generally needed to, because thinking didn't need to. So, no, that's really interesting here. Thank you very much. Councillor Welsh, Councillor Warren, was all the points covered?
Just one about the communication situation. It would be nice if we could get a small A4 or something even smaller than that and put it into shops, offices, libraries, cinemas. Just make sure that everyone is aware and gets the opportunity to know what to do.
Agree. So, Councillor Welsh, did you want to speak?
Yeah, it's one last request for information, just so I think as a scrutiny committee we need to be really clear on how this service is commissioned. In the sense and this is the bit that I need to get clarified before I get concerned about it, is what information you ask as a commissioning body from NHS 111, because you commission a lot of services that are crucial for people in Nottinghamshire, and we need to know what information you ask for, what information you get, and how you use that without putting undue pressure onto a service that I know is already under pressure. But I am concerned about the pressure that you're under, if I'm quite honest. I'm very concerned, and I'm very concerned that the services after people phone 111 aren't always there, and I've said this, you get the pink finger pointed at you, and I don't think that's fair. So for me, I need to know right from the start what happens with regards to you as a commissioning body and how we're using that information. I think it's absolutely crucial.
Yeah, absolutely. As well, I think rent that point now with summing up in terms of data that we'd like for. So I think what's really important is that we work with you, after the meeting as well. We've got the notes and the minutes, and Noel's got that all collated together to put together that data that members have requested to try to make sure we cover off all those bases and see obviously what the art of what's possible as well, obviously with your data, and so we can understand that. So thank you very much on that one. So I mean, in terms of the debate, I really thank colleagues for that. I think we've really gone into a lot of detail for your honest answers and giving us the information space you have there. So if we go to our recommendations, we've got a couple, which was consider and comment on the information provided, which we have done, and determine whether any further information was required for the committee's consideration. Well, I think, as we've just said there, we do need some more information coming back. So, the recommendation, I would add that the recommendation is that you ask myself as chair and the officer Noel to work with colleagues to make from the issue and from the ICB to get the data right that we need to bring back to committee, which then, in terms of bring that back, what I'd like to do first of all is we'll discuss that briefly at our next meeting if it's done at the time or one after, and then decide part of our work programme how we want to analyse that further. It might be that, let's say there's massive outlier to say it's about dentistry, taking one example, well, it might be worth we have a joint report with dentistry rather than standalone. So what it means we understand for that data how best we want to analyse and scrutinise it, rather than just saying one standalone item to bring everyone back, when it might be worth looking at in the right way. But also to add a fourth recommendation, which is to thank the 111 service and for you to feedback to your team how much we do appreciate it, because I think actually look at the increase in calls, and like I say, the pressure they're under. I mean, I've worked in customer service my whole life, so I know it's a lot harder than people think, taking calls and being the front line, so to speak, with residents, especially with the massive life and death, which it literally is in terms of what you're describing there. So if the committee agree with that, like that's fun recommendation, so you can hopefully pass that back to your team on our behalf. Is everyone on the committee okay with those recommendations? If show of hands, those four, all in favour? Thank you very much, and thank you very much for your time again. For hopefully we'll obviously be seeing you soon, but we can see you again in the future to just look at it again. But thank you very much for your time. Thank you. Home stretch, don't worry. Onto the work programme now in front of us. So a couple bits just to touch on before getting to the substantial item. I had a catch up with Nancy May in Israel there, and we discussed a few bits. And what I asked, which she's obviously more than happy to do, is for an interim report about the Octon review, because we know it's still going on for a lot longer yet in terms of in the next year the current timescale. I think it's really important as a committee we just understand where we're currently up to, because I know it's changed on a regular basis, comes in having in terms of cases brought forward and change there. So having an update till middle of this year, June, July time, to get that from NUH and on itself there. Would everyone be okay with that as a general point, Michelle?
Yeah, if anything with relation to the academic review, I think it's really important that you make every effort to contact the families directly.
Absolutely,
so they're aware, and also make sure that Donna is aware of.
I know she's at work for personal reasons at the moment. When she's back, obviously, I'll have a conversation with her. Absolutely. Sorry, Councillor McGrath. Sorry.
Are you all right, Chair? Could we consider actually putting the parameters of a critical incident? Because I've had a number of people come to me who have been concerned, how they were discharged and something like that. We need to know what is a critical incident and how we deal with it when it's out there. Because going back to 111, I'm sure their calls when us as a nation, they're all over, decide what a critical incident is, their calls must be through the roof. So if we could have parameters around it, or someone to explain to us what a critical incident is, I think we're well aware, but I think the people need to know what one is.
Do you think it'd be best, first of all, if we got a brief note to define that first of all, because I've rather scrutinised there, then we look at that and you believe from the committee after that, from reading that information, believe we need to scrutinise that further, then we bring it for a standalone item. That'll work better. Just to make sure, first of all, the information might be enough. If not, absolutely, we look at that for a further. Is that okay? Thank you. And sorry, I will come back to the work myself. So just one more bit before that. I just want to, before we get into this substantial work programme, just touch on the school readiness item. So as you know, Councillor Reddy has been leading on that and just got a few updates before we go into the main other parts of the work programme. Councillor Reddy.
I'm sorry we've not had a meeting so far. I had COVID over Christmas and I've been really poorly, so I'm a bit behind. But we're hopefully going to have the first meeting around the 9th of Feb. So it gives us time to get an idea of what we're doing. But we'll be in touch with people who have signed up to say they want to come, and we'll start that as soon as possible. But I'm sorry I'm a bit behind because I've been quite poorly over Christmas.
No, you should know it's for that, but I think it's also worth saying, you've had the meeting with officers just to go through, and I sat in there as well just to get the feedback on that as well, but that can certainly lead in terms of just to go around scoping and understand from colleagues. So that work has been done behind the scenes for to prepare us ready for that meeting. So if we go into the substantial work programme itself, so did you have a question on that before I go on? Yeah, that's what.
Thank you very much. One thing that I've raised repeatedly in this committee, and it is now listed in the work programme, is the health and wellbeing provision in Hucknall, and in particular the Cabell Centre, which was the proposed super health centre in Hucknall. Now it's been over 6 months since the NHS went public and broke their promise to the people of my town. Since then, they've made no progress. So what am I actually asking? You've got it in the programme. Can I formally propose that we invite the NHS bosses, including the ICB, to our March meeting to give us an update on where we are on this situation? Because it has been ongoing for a number of months, and this issue I need to get to know. Well, the people of Hucknall need to know, and I think we ought to know exactly where this Cabell Centre is at the present time.
Okay, first of all, it's not been off the work programme. It's been on the work programme for at least the last 2 meetings where I've been looking at. I've been to the one before, so it's never been off the work programme. I think we mean in terms of scheduled in, because my understanding from going through it and the understanding is at the minute the reason not being put forward to scrutiny is because we've been waiting on the NHS and the local council in terms of understanding. There was a location, I believe, was it, where it was going to go. From what I lived knowledge of it is that they're there, and understanding. Yeah, so I know it's about NHS. To me, they're one part of that. So if first of all, if we go away just to try to understand with the various partners where we're up to, if we can move it forward. So what I'm conscious of is, if we invite them in and they just do it initially go, it's not us, it's not them, it's a waste of everyone's time and your time for your resident there. So I think first of all, my recommendation would be we go away and contact them beforehand, find out, is there an update they can give us? If not, why not? And with it, then I'm more happy to have a conversation for you to find out then, is it then relevant to bring forward to the scrutiny item? See what I mean? I don't want to give false impression. We go, yes, we're going to scrutinise and get a solution. They sit there and go, it's not just because A, B, C. That's not going to help anyone, is it? Especially resident help on Nottinghamshire. So if you're okay with that, let's have that conversation with partners. Then I'll get in touch with you. We'll have a conversation, see how we take that forward.
Thank you very much.
Thank you. So in terms of where we are for our next meeting, as you know, we've got one. Sorry, actually, let me bring rather me whistle on, bring Noel to talk about it more further.
Fair.
Sorry, put you on the spot now. There you go.
No, sorry. Yeah, we have a definitive item definitely coming, which is the mental health services and support in schools, which has been requested as a matter of urgency. So that's definitely coming along. The reason, to be frank, the reason why there isn't more firmed up is that I was waylaid with COVID for some time between the last meeting and this, and what I'm looking to do, as I said before, was to to prioritise the issues that had been raised at the December meeting to reinvigorate the work programme. I simply haven't been here to do it, so I'm fighting fit now, so we'll be moving that forward as quickly as my healthy little body will allow.
We completely get it. No, thank you for that. Like I say, and I know even when Noel was ill, he was still trying to be ordered to go recover and to get right. So I really appreciate that we've done that. I think it's obviously with the dentistry item as we talked about earlier on. I think let's get that report back. And as I said earlier, if we at the next meeting, if we've got it part of the work program, we discuss it and see how that might feed in. As I sort of alluded to, well, our guests were in here about does it work? Standalone items have to work. So about dentistry itself, let's bring that back as well as one just to understand is there something else we want to scrutinise. So we'll discuss that report once it comes forward. So I'll circulate it once we have that information we asked for, and then we can discuss how we want to scrutinise that going forwards. And same with the 111 service as we just touched on there. So when we get that data, let's understand how it works, how it should be scrutinised, and factor that in. Obviously, we've got a few items that are to be programmed. I know Councilwoman alluded to one and others. So I'm going to sit down with Noel and obviously with Beth to look through these more details, see where we are in terms of realistic timescale, because I think it's worth, obviously they're on the work programme, but we need to actually know how long they would actually turn around to a meaningful report. That's the thing I think any of us wants to do, is have an item on scrutiny that isn't right or is undercut and doesn't deliver what we want it to do. So we'll have that and to bring a full update for you at the next meeting, how these items are, how they're progressing, then we determine how we want to order those going forward based on what we've had there. Obviously the Newark Treatment Centre, obviously we don't have an update as now, that's why it's not on the agenda. I am meeting later on with Lucy to just understand where we're up to, so once I have any updates you'll all know, and then we can determine again, as I say, if it's right for the next meeting, if there is a decision made that we want to bring that back, or again we look at in the future to bring that a predetermined date that's best to scrutiny. So if everyone's okay with that, that's where we currently are. Any other question on the work programme itself, any bits to add in? So if everyone's okay with that, so we'll take it away and we'll be obviously communicate out to everyone how we've gone. And so thank you for that. I really want to thank everyone for today. I think, the level of question you asked was fantastic. And in terms of, the two really important items, don't look as the second side, so to speak, if you look at first agenda, but actually those two affect all our residents. And we did a good service today in terms of asking this question. So thank you very much, everyone. And sorry, before Beth and Hurt kicks me again, the 10 a.m. start. So is that work for everyone? Well, I say yeah. You didn't want to be grilled on the way, probably, but. So if everyone's comfortable, the reason for 10 o'clock was for a couple of reasons. I mean, first of all, we get to the stage where we are now where it's not people going, it's time for lunch, is it? Are we getting over? But also, I know a lot of people have afternoon meetings, which is why people have to leave into previous meetings towards the end, because, again, we know it's not just here on the busy day. So if we keep going at 10 for now, I'm not saying it's permanent instead for next 50 years, it's for now, and if we think it's changed on a regular basis, we can, it's up to them. If anyone's got any issues, come and see me privately, and we'll have to discuss and see how we take forward. But if we say for our next meeting, we'll definitely be 10 a.m. And go from there. Is that right?